Welcome to this talk on nevogenesis and melanomogenesis. Over the next 15 minutes, I'm going to give you a whirlwind tour of what we have learned, the insights we have gained over the last 20 years with the use of dermoscopy. And what the intent of the lecture is to challenge some existing hypotheses, to propose some new ones, and confirm some existing ones. So it's food for thought. And this is the outline that we will go through. And so let's talk about nevogenesis first and talk a little bit about inception. And one of the insights that we gained with dermoscopy was very early on that there are incipient nests in the skin, at least in some individuals. And so by looking at the dermoscopic pattern of background normal skin, we were able to discern that there are, in fact, on occasion, incipient nests, and this was published in this paper. But basically what we did is we looked at children in U.S. schools and followed them over the course of time, so it's longitudinal follow-up. And we also imaged the nevi and the background skin. And in these patients, what we noticed is that there are three types of background skin. There are globular background skin, reticular background skin, and homogeneous background skin. And what we found was when looking at the globular background skin, we wanted to find out what these background globules actually represent. And when we did Mohs sectioning of normal skin, we found that there were indeed some incipient nests that were present. It was not a one-to-one correlation, but there was a strong correlation between the background globular skin and having these incipient nests. This same phenomenon has also been shown in the world of histopathology, where when they looked at normal skin and they step sectioned it, they found that there was a percentage of individuals that harbored these incipient nevus nests. And we hypothesized that at least some nevi, maybe the so-called Clark's nevus, large acquired nevi, the nevi with peripheral globules, that they may arise from these incipient nests. So one can actually consider them sort of like tardive congenital nevi, right? So you were born with these incipient nests, and then later on in time, at some point, they broke through senescence and started to grow. What do we know about evolution? What we know is that there probably are biologically distinct subsets of nevi, and we will go back in time for a moment and just talk a little bit about Unna's drop-down theory as in Kramer's move-up theory of nevus evolution, and show you that the dermoscopic data actually does not support this. And basically in the Unna's theory, they say what Unna proposes that the nevi start at the junction, and over the course of time they become compound and eventually intradermal nevi, whereas Kramer proposed that it follows embryogenesis in that the nevus cells or the melanocytes move along the nerve bundles into the dermis and then eventually into the DE junction. So you're initially dermal nevi that eventually become junctional. I'll share with you two studies. There are more than these, but highlight two. One is based on cross-sectional data, and one is based on longitudinal data where the same lesion is followed over time. In the cross-sectional one, what we see is the dark bars represent globular nevi and the light bars reticular nevi. And you can see that the globular nevi, by and large, are seen in younger individuals, and the reticular nevi are seen in older individuals. If we look at the longitudinal data, what we find is that whatever nevus type you have initially, it's the same pattern that is retained over the course of follow-up. So reticular nevi do not become globular, and globular nevi don't become reticular. So nevi retain their original pattern. Some may involute, some may become homogeneous, but they don't turn from reticular to globular or globular to reticular. So in a child, one can already predict that most of the nevi will have a globular morphology, and in adulthood, one can predict that most of the nevi will have a reticular morphology. So if we look at the Unna's theory, right, so it says that you would start off as a junctional nevus, become compound, and then intradermal nevi. So what you should see is early in life reticular, then both reticular and globular, and then eventually globular. But in fact, early on in life, we don't see a reticular pattern, we see a globular pattern, and then immediately there's a shift to a reticular pattern. So you don't see this intermediary group of reticular globular, and then obviously in older age you see a reticular pattern instead of a globular pattern, and hence Unna's theory can't be correct based on the dermoscopic data that we have. In terms of biologically distinct subsets, that's really the emerging thought now. So you are born or you develop a nevus that has a specific mutation that leads to a type of a nevus. And so what that suggests is that neither Kramer's theories or Una's theory are correct. Most nevi retain their original overall pattern. And we can sort of take a look at some of this, like for example, blue nevi have GNAC mutations and congenital nevi NRAS mutations or BRAF mutations. Acquired nevi have the BRAF mutation, and obviously Spitz nevi with their set of mutations, and then you have the BAP1 deficient nevi. So every nevus has its own signature, and it's a unique, distinct subset. In terms of growth, what do we know? There are two types of growth we've identified. One is with peripheral globules, one with streaks. So these peripheral globular nevi are basically seen in Clark's nevi that are in their radial growth phase before they have entered senescence. And the first paper that highlighted this is here, and on the left-hand side you will see this perfect peripheral globular nevus, and if you follow this lesion over the course of time, it will become symmetrically larger, and the globules will become sparser and fewer, and eventually when the nevus enters senescence, it will no longer have any globules at the periphery, and the lesion will either be reticular or homogeneous in its pattern. We have also identified that the rate of growth of these of these nevi can vary from 0.12 square millimeters per month to as high as 0.52 millimeters per month. And what we've also noticed is from the time of inception, when you see the first signs of a new nevus developing with peripheral globules, to the point of senescence, it's about 5 years. It is interesting to note that if you compare this to the rate of growth of melanoma, and you convert the paper that is highlighted here and into the same values that we just published for growing nevi, you will notice that the rate of growth of melanoma and the rate of growth of nevi is actually exactly the same. So really the only thing that differentiates the rate of growth between nevus versus melanoma is the nevus enters senescence and the melanoma theoretically does not, and it will continue to grow. But the rate of growth appears to be the same. In terms of streaks, this was identified in Reed's nevi, so the starburst pattern. This is also the radial growth phase of the Reed's nevus, and basically what you see is you have this peripheral globular peripheral streak-like pattern as depicted here, and this lesion will become symmetrically larger, the streaks will become smaller and thinner, and eventually when the Reed's nevus enters senescence, those streaks are no longer visible, and the lesion has homogeneous brown with a central bluish hue. And so basically, the peripheral globules and the streaks both represent the radial growth phase, one of a Clark's nevus, one of a Reed's nevus. One has junctional nests at the tips of the Reed ridges, and the other one has confluent junctional nests at the D junction. This represents the streaks, and that represents the peripheral globules. In terms of involution, dermoscopy has allowed us to notice that there are multiple ways that lesions can involute. And basically, you can have the halo phenomenon, which is thought to be T-cell mediated, peppering or type regression, which is apoptosis. And then there's a theory that perhaps another way is transepidermal elimination of melanocytes. In terms of the halo reaction, which is T-cell mediated, we know that the predominant nevus that undergoes this type of involution is the globular nevus, and so you'll have a globular nevus develops a halo, and eventually this globular nevus becomes smaller and smaller and eventually disappears, and then over the course of time that halo also repigments and you have normal skin. The entire timeline from inception to normal skin is thought to be about 5 years, and I'll highlight this paper for you to read regarding that. In terms of regression or apoptosis type involution, it is also seen not very commonly. Here's a small congenital nevus that basically has peppering type regression with some scarring, and slowly the lesion has completely disappeared and the skin is becoming normal. And then the third is a theory, which is transepidermal elimination, that nevi just slowly fade away. There's no reaction seen, no peppering, no halo, and slowly fades away. And there's some evidence that perhaps this is due to the fact that the melanocytes are being expelled out of the skin, and so it's transepidermal elimination. Let's switch over to melanoma genesis and talk a little bit about origin of melanoma. And I think it's fair to say that dermoscopy observations have supported the concept of stem cells as the origin of at least some melanomas, giving rise to lentigo maligna, superficial spreading melanoma, nodular melanoma, and, and acrolentiginous melanoma. So stem cells sitting in different parts of the skin, so along the dermoepidermal junction in the hair follicles, along the acrosyringium, and also in the dermis. And if we look at lentigo maligna, the theory is that the stem cell in the hair follicle is the origin. So the melanoma preferentially grows in the hair follicle. It then goes across and inhabits other hair follicles. So in early lentigo maligna, it's all the findings are follicular-centric. Then you start to develop the melanoma in between hair follicles, and you get the lines. So those are your angulated lines and your rhomboidal structures, and then eventually it becomes invasive with homogeneous areas. And dermoscopy supports this, that it's all sort of early on follicular-centric in lentigo maligna. In superficial spreading melanoma, the theory is that the stem cell is at the dermoepidermal junction, and then you basically have spread along the dermoepidermal junction and prominent pagetoid spread, right? So this is the moving up of these melanocytes in the epidermis, and then eventually becomes invasive. And if you look at a nevus, a junctional nevus, and compare it to in situ melanoma, you'll notice that they appear quite similar, because it's the dermoepidermal junction which gives you the network appearance, which is very prominent. So in melanoma in situ, that network is being disrupted, so it'll be more atypical than in a junctional nevus, but it sort of supports this idea that it's along the dermoepidermal junction. And confocal microscopy also shows that in superficial spreading melanoma, it's very common to see these pagetoid cells in the epidermis, so the dendritic cells and large nucleated cells. In terms of nodular melanoma, here the theory is that the stem cell is in the dermis, or in the papillary dermis, let's say, and then you basically have a ball that's growing and eventually involves the epidermis as well. And so symmetric kind of growth, uninhibited growth. And again, just to compare an intradermal nevus on the left and a nodular melanoma on the right, you can kind of appreciate how similar they appear in their dermal nature or morphology. And not surprisingly, these, at least in early nodular melanoma, pagetoid cell is not a very prominent component, and confocal microscopy has confirmed that there's not a lot of pagetoid cells. And in acrolentiginous, we know that the acrosyringium is around the acrosyringium is where the stem cells are located for the melanocytic stem cells. And if you notice on the histopathology, the acrosyringium opens up on the ridge of the dermatoglyphics. So melanoma preferentially grows around the reedy ridge associated with the acrosyringium, and hence you get the ridge pattern, at least in early a melanoma in fair-skinned individuals. And here is your ridge pattern, highlighted pigmentation on the ridges. You can see the acrosyringeal openings here as well, highlighting the ridge pattern. The other thing that we have noticed with dermoscopy is that there is such a thing as an indolent melanoma, and this is important, especially given the light of recent study, paper, or opinion piece, lowering that they don't kill the patient in their lifetime. And we had shown this also dermoscopically many years ago, that there is a subclass of melanomas that grow very, very slowly. The conventional thought is that melanomas have a linear rate of growth, with nodular melanoma being the fastest and lentigo maligna and superficial spreading melanoma being slower. However, we also have many cases that we have seen over the course of time, especially with digital monitoring, where the rate of growth is actually quite slow. And here is just one example of a lesion that was followed over the course of 5 years, and when it was finally removed based on change, it was a 0.2 millimeter melanoma, and it was not associated with a nevus, so one can assume that it was a melanoma even in 2015, but still a microinvasive melanoma. So the slow-growing melanoma story was highlighted first in this paper. Basically, there were multiple centers around the world that were asked to submit cases where there was a lesion melanoma that was unintentionally followed for at least 1 year, and then eventually biopsied and shown to be a melanoma. And it was found that it's not an uncommon event. And here's just one example of that, of a melanoma 0.5 millimeters that was followed over 41 months. So you can see the rate of growth very, very slow. So sort of these are these indolent type melanomas. Obviously, that one can theorize or hypothesize that these very slow-growing melanomas may be contributing to the overdiagnosis of melanoma, but as of today, we cannot differentiate based on morphology between those melanomas that will go on to kill you versus those that will remain indolent. And so further research will be needed to dissect that apart a bit better so that we can outline therapy better. And then lastly, I'll talk about progression. And we know that there's matrix remodeling in melanoma, and this, at least dermoscopically, the insight came from the observation of shiny white lines seen under polarized light. And what I'd like to highlight is while melanoma interacts with many, many cells in the skin that allows the melanoma to grow, there are two issues. One is stromal induction with fibroblast proliferation. And at the same time when stromal induction occurs, you also have neoangiogenesis. And these two factors actually go together at the same time. So the first paper, or one of the first papers that highlighted this, is here, and basically what we showed is that melanomas are more likely to compared to nevi to have these shiny white lines, and we know that these represent collagen, and we also know that the invasive melanomas, 41% of them had these shiny white lines. In situ melanoma, only 17%, and if you looked at the invasive melanomas only, the ones with the shiny white lines were thicker tumors compared to ones that did not have shiny white lines. And as I mentioned, that the two are combined. So once you have stromal induction, you also have neovascularization, and this neovascularization is present in the dermis, including the papillary dermis, and this is visible on dermoscopy, obviously, as atypical vessels. And so this is very common that when you see shiny white lines, you will also see vessels, and you can see these polymorphous vessels throughout this melanoma, and here the shiny white lines. They're not very prominent here, but here are the tiny little shiny white lines. You can see them all running sort of parallel to each other, and then all these serpentine vessels throughout. If we look at the data, and you look at the vascular structures, when shiny white lines are absent, only 12% of those lesions revealed vessels, whereas if shiny white lines were present, 88% of those lesions revealed these atypical vessels, again supporting the fact that these two, that stromal induction and neoangiogenesis occur together. And then lastly, I will highlight another area that requires further research, and that regression seen on pathology actually encompasses two things, which in my opinion, both regression to regression and another idea of progression. And I'll highlight that schematically. So melanoma, at least superficial spreading, grows along the DE junction. There is attenuation of the DE junction, but there is pagetoid cells and there's stromal induction. So you get shiny white lines and vessels at this point, and then you eventually get invasive. Very different from regression, where you don't have pagetoid cells, you have fibrosis without the vessels and without without neoangiogenesis, and you don't have organized fibroplasia, so you don't see the shiny white lines, you just see a porcelain white appearance. And so on the left-hand side, this is regression as seen with dermoscopy, porcelain white, peppering throughout, flat, non-palpable. This is progression. You see in here, there are shiny white lines. There are also tiny, tiny little dotted blood vessels in here. And this, histologically, is also reported as regression, as is this. But this is regression of a melanoma, involution of a melanoma. This, on the other hand, is setting the stage for invasion, so it's progression of melanoma. Histologically, they both are reported as regression, and I think this is where lies much of the controversy regarding regression. I theorize that true regression, as shown here, is a good sign, and obviously this type of regression is actually not regression. That would be a poor sign. And so this is the summary of that. Regression is porcelain white without any shiny white lines. There's peppering granularity. It's flat, not palpable, and you do not see blood vessels. In progression, you have shiny white lines, blood vessels, and it tends to be slightly raised in a palpable component. And I close with this quote: "Discovery consists of seeing what everyone else has seen and thinking what no one else has thought." Hopefully I've stimulated some thought, and I thank you for your attention. I wish you a wonderful and a peaceful day. Good day.
Dear colleagues, I'm Zoya Palla from Thessaloniki, Greece, and this presentation is about the insights gained from dermoscopy in keratinocyte skin cancer. 3 decades ago, and before the introduction of the dermatoscope in our daily practice, when we were in front of a lesion like this, we were not able to definitely reply if this is a melanoma, a seborrheic keratosis, or a pigmented basal cell carcinoma. In this context, also, the management decision was troublesome. Today, with the use of our dermatoscope, we can reply with confidence that this is a pigmented basal cell carcinoma. Also, the clinical type of this basal cell carcinoma is non-superficial. Why? Because we recognize these blue ovoid nests, meaning that at this point we have deeper-seated basaloid nests. And in this context, surgical excision is the optimal choice for this patient. Apart from this, we have an additional clue. We can realize that there is a foci of basaloid nests, that it is not apparent by naked eye clinical examination, and this highlights the usefulness of dermoscopy also in determination of the surgical margins. In the spectrum of actinic keratosis and squamous cell carcinoma, again, we would treat this patient without the application of our dermatoscope as actinic keratosis. However, with the application of our dermatoscope, we can recognize clues of infiltrative squamous cell carcinoma, like the atypical vessels linear together with dotted vessels and the ulceration, and all these criteria speak for an infiltrative squamous cell carcinoma, so the optimal choice also for this patient is surgical excision. In the early phase of the research in dermatoscopy, our main focus was the description of the criteria of pigmented lesions versus the criteria that correspond to melanoma. And in this very educative paper, we can read the list of the criteria characterizing the pigmented basal cell carcinoma. However, at this point, the description was generic, and at this point, we did not separate the criteria for each specific subclinical variant of BCCs. This happened a few years later with this paper. This was one of the first papers trying to discriminate superficial versus nodular BCC, and the authors of this paper mostly focused on the vessels, vascular criteria, describing that, in fact, the superficial BCC is characterized by the presence of short fine telangiectasia, and no thick in-focus arborizing vessels are present in this specific subtype. The sequel of this paper in the literature was this one, performed by Emilios and our group. And in this paper, we designed a study we presented the result of a study in which we tested the accuracy of dermoscopic criteria for discrimination of superficial versus all the other basal cell carcinoma subtypes. And in fact, we were able to identify that brown color, maple leaf-like areas, small erosions, and short fine telangiectasia are positive predictors of superficial BCC and predict the diagnosis, this particular diagnosis, with a high sensitivity and specificity rate. This is clinically relevant, all this data from the literature. Why? Because now, immediately with the clinical and dermoscopic examination, we know that when we are in front of a superficial versus a nodular BCC, and we can apply the optimal therapeutic management for our patients, not only in non-pigmented, but also in pigmented basal cell carcinomas, like in these two similar on the clinical basis cases, but dermatoscopically it is clear enough that we can only observe brown coloration, meaning superficial structures, versus the bluish coloration, meaning deeper-seated basaloid nests in the case of the lesion on the right. These publications in discrimination of the different variants of BCC did not stop in the superficial BCC, but there were many other publications describing also other rare, though potentially aggressive variants of BCC, like, for example, the metatypical basal cell carcinoma. And in fact, it was shown in this publication that vasosquamous carcinoma is characterized dermatoscopically by the combination of at least one BCC and at least one ACC criterion. So when we have a patient like this, we can recognize white structureless areas, white circles, follicular plaques that are criteria of squamous cell carcinoma, and in the combination with the blue ovoid nests and the arborizing vessels that are criteria of basal cell, we know that probably this tumor is a metatypical carcinoma, and we should take immediate action since this tumor is more aggressive as compared to other BCC subtypes. Not only for metatypical basal cell carcinoma, but also for the infiltrative variant. We have this recent publication describing the dermatoscopic pattern of this specific clinical variant, that it is characterized in dermoscopy by the presence of ulceration, arborizing fine superficial telangiectasias, and shiny whitish areas. In fact, the vascular pattern is created by this in-focus network of vessels. With the introduction of topical treatments, of many topical treatments in the armamentarium of dermatologists for the management of basal cell carcinoma, another need was raised, the need of a tool for being able to monitor the treatment outcome of all these non-ablative techniques. And indeed, this resulted in this study in which we evaluated the applicability of dermoscopy in treatment monitoring of patients undergoing non-ablative therapies. And in fact, we found out that in the absence of any criterion after the end of the treatment, the possibility of residual disease is 0%, versus the second scenario when we see pigmented structures or ulceration and arborizing vessels. And in this case, the possibility of residual disease is 100%, meaning that we have to go on with treatment. And in the end, the third scenario, short fine telangiectasias and translucent whitish and pinkish areas raise this possibility up to 30%. And in this case, maybe the best choice is to set the patient under close monitoring. All these advantages would not be gained if we did not have all these studies about the correlation of the dermatoscopic features with the anatomic alteration responsible for these features. And indeed, in this editorial paper, Professor Tanaka highlighted this insight gained from dermoscopy. He underlined that this equipment is the equipment to lessen the gap between the macroscopic and microscopic disease. All this research started many years ago, from 1989, with very beautiful studies of Peter Sawyer and his co-workers. And until the recent years with these publications that incorporated more sophisticated tools to examine the precise correlation of each dermatoscopic criterion with each specific anatomic alteration in histology. For me, the studies that investigated the role of the quantity as well as the depth of melanin in the skin and the color variation projected in dermoscopy are very important, because we know that the higher the amount of the pigmentation and depending on the localization of pigmentation, we have different color projection in dermoscopy. The deeper the melanin, then the more bluish the coloration of pigmentation. If the pigmentation is superficially located, then the coloration is black or brown, and so on. This study is very important, and anyhow, these studies of the correlation are very important because they led us at this privileged position to be able to have a clue about each specific criterion in BCC and ACC. When we examine our patient, we have the perfect correlation with histology, and we now know that when we see a patient like this with this thin grade 1 actinic keratosis displaying the red judo network. This red judo network is created by the dilated vessels in the upper dermis, which is thin and atrophic, and as well as the white dots correspond to the widened follicular opening filled with the keratin plaque. In the same way, for Bowen's disease, we know that these granules of pigmentation, these brown-gray pigmented granules, correspond histologically to the presence of these dysplastic cells within the epidermis that are dispersed in the epidermis. And in the same way, for coiled vessels, we know that this is the result of acanthosis and the presence of tortuous hypertrophic vessels vertically oriented in the papillary dermis, and this creates this pattern with coiled and dotted vessels here and there. And we know that this pattern can be also seen in psoriasis, in fact correlating with a very similar in terms of histology anatomic alteration. White circles in squamous cell carcinoma are the result of an acanthotic epidermis and of the presence of these keratin plaques filling the dilated follicular opening, and this creates this beautiful pattern of white circle encirculating a yellowish or brownish central area. All these morphologic studies in dermoscopy resulting in better understanding of the so-called progressive model within the spectrum of squamous cell carcinoma, with this very important publication in which the authors describe all this gradual process from actinic keratosis towards invasive squamous cell carcinoma. And in fact, it was shown that the development of hairpin and linear vessels together with the ulceration indicate progression towards invasion. This paper is very important, and this understanding of this progressive model is important. Why? Because we now, with the examination of patients like this, we know at which specific stage of this progress is every lesion that we examine, and we are able to discriminate among all these lesions the squamous cell carcinoma and optimally treat our patients. The knowledge of specific patterns linked to different stages of this continuum improve the clinical discrimination of in situ versus invasive SCC at earlier stages, and also this facilitates treatment selection, monitoring and outcome. What do we mean when we say management based on dermoscopy? This is a very representative example. In this patient, we examined dermatoscopically this lesion, ulceration, atypical vessels, wide structureless areas. This is an invasive squamous cell carcinoma, so we should go on with excision, opposed to these thin hyperkeratotic lesions that correspond to actinic keratosis, so field topical treatment for these lesions. In the end, this lesion displays criteria that could correspond to early invasion like white circles, follicular plaques, white structureless areas, and in this case, this lesion deserves a histologic examination. Early recognition of invasion is very important. In this direction, we performed a study designed to find criteria that could correspond to early invasive squam in the background of actinic keratosis, and we found out that linear hairpin vessels, dotted glomerular vessels, and white structureless areas were positive predictors of early invasion. So in a patient like this, on the clinical basis, it is really difficult to say if this is an actinic or a squamous cell carcinoma. However, atypical vessels, ulceration, white structureless areas indicate an invasive squamous cell carcinoma. In the same way, in these tiny lesions that could be missed as folliculitis or an actinic keratosis, ulceration, white structureless areas, and white circles indicate an invasive squamous cell carcinoma. All this progress did not stop at the early recognition, but also in the possibility of being able to discriminate the differentiation by the use of our dermatoscope. And indeed, it was shown in this study that the more white is the color of the colors in dermoscopy, the better the level of differentiation versus poorly differentiated squamous cell carcinoma displaying red coloration corresponding to the vessels of the supportive vessels of the tumor. So in front of our patients, clinically relevant, a well-differentiated case of squam in the first case versus a poorly differentiated squamous cell carcinoma in this case. From the insights gained with the use of dermatoscope, we cannot miss out to mention the contribution in the development of machine learning algorithms and automated diagnosis. It is generally accepted that the contribution of dermatoscopy was huge and very important. At this point, I would like to conclude that from early diagnosis, subclassification, management decision, and treatment monitoring to machine learning and automated diagnosis, dermatoscopy significantly contributed to the deeper knowledge of keratinocyte skin cancer. And importantly, the research in dermatoscopy perfectly exemplifies patient-centric research, since it constantly aims to integrate knowledge into practice towards the improvement of our patients' lives. Thank you for attending.
Hello? I think we don't have
Now, in 5 seconds, start the discussion.
And Rania is not here.
And also Asmar Hub is not here.
No.
Okay.
That's fine.
Okay. A ver. Okay. Ready, Chris?
So thank you so much. We have had 2 wonderful talks, and it has been really, really teachful. I think that we don't have here Asmar Hub. He apologizes because I think he has a familiar commitment. It's a pity, but good for him. And I think Rania Hoffman, I think he's not with us. So he's sorry again, but anyway, we are here together to have some minutes for comments. So if any of you want to begin or to start, thanks so much.
So Zoe, thank you so much for the talk. I think it's a very innovative approach to non-melanoma skin cancers. in solar keratosis and differentiation of the progression model. So I wanted to ask you, do you have any insights based on this progression on factors that give rise to squamous cell carcinoma? For example, what is the role of trauma in the induction of squamous cell carcinoma? Or when does squamous cell carcinoma, do you see it in association with a solar keratosis versus de novo?
Well, I cannot correlate for sure the history. First of all, thank you for the question. But of course, I cannot correlate the history of a trauma with the development of squamous cell carcinoma based on evidence, because we don't have such an evidence. We know from the studies, from the data, that in the background of chronic inflammation, like discoid lupus erythematosus, we can see the development of squamous cell carcinoma, and maybe this kind of chronic inflammation, if we consider this a kind of trauma in the tissue. I don't know if we can extrapolate this kind of process also to the mechanical trauma, chronic mechanical trauma. However, I'm not aware of such an evidence in the literature of correlating chronic trauma with the development of squamous cell carcinoma. I don't know if any of you have a clue about this.
We know that, hello everybody, it's very nice to be with everyone. I think that we have so many risk factors for developing squamous cell carcinomas that come from viral agents to immunosuppression, UV radiation, and trauma has been always thought to be one of the possible mechanisms because of matrix remodeling and other scenarios, like we see, for example, in scars of some traumas from the past. So maybe it could be possible. I don't know what you think, Alan, but something is also difficult to find out with studies. But well, maybe it could be. I don't know what you think.
Yeah. So I was wondering, because sometimes patients make the comment that this site was a site of trauma. I sometimes thought that maybe since squamous cell carcinoma could be painful sometimes to the touch, maybe a trivial trauma was thought by the patient to be an inducer, but actually they felt the place when they touched it or something like that. But I've had this come across in the history of some of the lesions that were eventually found to be squamous cell carcinoma. My second question, Zoe, was we know that there are those squamous cell carcinomas that develop de novo, or those that develop on the background of actinic keratosis of chronic sun-damaged skin. Any insights on dermoscopy to this line of evolution versus that line?
This is very important in my viewpoint to discuss, because we know that the rate of well-differentiated squamous cell carcinomas is higher when the squamous cell carcinoma develops in the background of actinic keratosis versus the squamous cell carcinoma developing de novo, meaning that the squamous cell carcinomas that develop de novo are usually in higher rates, are poorly differentiated. And this can be observed with the use of the dermatoscope, because we know that we have criteria of well-differentiated versus poorly differentiated squamous cell carcinoma. We mostly see when it is de novo, the vessels, the atypical vessels, and we do not see any white criteria corresponding to the keratinization that we do not expect in a poorly differentiated squamous cell carcinoma.
In my view, regarding this very interesting point, I always wonder, because you know what, when we treat squamous cell carcinoma in the context of multiple actinic keratosis, of course, we know that this is a cancerization field. Sometimes we have plenty of lesions, we have collision tumors, and sometimes we don't know exactly what we are treating. This is sometimes my view, because I have had some patients where you treat some of the most keratinizing lesions. You think that most of them are AKs, maybe incipient squamous cell, but well differentiated. And especially after PDT, after therapies that you treat the whole field. And when you check the patient maybe 6 months later, the field has improved, but then you discover one not so incipient tumor. You know what I mean? So I don't know, maybe we need further research in that, but maybe when we, when you clean the area, maybe you discover other things, and maybe this could be related also with the comment that you did, Zoe.
Yes, Christina, I definitely agree with you. In fact, since we deal with patients with multiple coalescent lesions, at baseline, we have no idea if there are hidden, let's say, already invasive tumors in the field. And there is a big discussion if we should start in the end with the field treatment and then go on with the more, let's say, invasive intervention with the surgery. So we can use the field treatment to clean the inside to part of the progressive model, let's say, and then we will be able to recognize in a better way where are these foci of invasion. For sure, I do not believe in any way that this is the development, the possibility to observe these tumors after a certain point, it has been created by the use of the treatment. Treatment is not responsible for me. The reason for this, my view, is that we were not able at this early phase with all this burden of actinic damage to recognize where is the invasive versus the in situ part of the cancerized field. Another important point is that, as Alan already mentioned, is that if in a field a patient complains for pain in a specific site of this field, then we should focus and biopsy this particular site because it is maybe an already invasive tumor at this point. And we know that actinic keratoses are not painful. They do not infiltrate the nerves, so the pain is related to the infiltration of the dermis. So it is better to go on with this clinical sign, with a biopsy.
Yeah, sure.
Yeah, and in line with these comments, I think it's very important to say that most of those lesions, they have, as we have also in melanocytic lesions, like a gray zone when we talk about dermoscopy. That means we can't only with dermoscopy maybe not differentiate hypertrophic actinic keratosis from an early invasive squamous cell carcinoma. So we need clinical aspects like symptoms, clinical inspection, and of course, when we deal with those patients and they have such multiple lesions, sometimes we just deal with the clinical scenario. We have a papular lesion that can be one or the second, and the way we are going to treat them is biopsying and surgically. That means we see the clinical scenario. In this way, dermoscopy helps maybe to differentiate low-grade actinic keratosis or even a highly suspicious squamous cell carcinoma. But this gray zone is important also to consider and to treat as it would be maybe a squamous cell carcinoma.
Mm-hmm. We have an interesting question, maybe an unresolved question, is regarding Ash's talk, but I always say that he makes us think a lot. So even without him, we need to talk about his talk. There is a question about what's your opinion or our opinion about slow-growing melanomas in contrast to melanomas developed within a nevus. And then a colleague is asking if from the dermoscopic research, do we have an answer for that? Can we differentiate the slow growing in contrast to these melanomas developing in a previous nevus? What's your point? Or
well, in the majority of cases, we can discriminate morphologically melanoma developing in the background of a nevus. There are many papers in the literature describing many criteria like the island sign and so on. However, there are always cases that we surgically excise suspicious melanocytic lesions, and we do not believe on the clinical and dermoscopic basis that there was a pre-existing nevus at this lesion. However, the pathologist comes back with a report describing a pre-existing nevus in this melanoma. I don't know if there is still a gap in this morphological, this particular, in terms of morphology type of nevi, however, of melanomas arising in the background of this specific nevi. I think that this is mostly related to the presence of deeply seated melanocyticness of the nevus that are long-standing, and we miss to recognize with our dermatoscope. I think that there is still a field there that we can examine more, we can study more.
Yeah, I think Ash alluded to that in his talk, that many of these cases would be a melanoma associated with a congenital nevus, a small congenital nevus, where you see some of these nests in the dermis. And the question is, was there a nevus that was clinically apparent? Was there a subclinical nevus? Or maybe even there are seeds in the dermis that are induced to a little bit proliferate by the melanoma microenvironment, or let's say growth factors. So all these scenarios can come into play. I think theoretically, when you talk about melanoma associated with a nevus, I think there should be also a distinction between a melanoma associated with a reticular nevus and with a globular nevus. And I think one could conjecture that a melanoma arising in a reticular nevus may be a little bit slower growing than a melanoma associated with a globular nevus. I know that Kitter has shown that a melanoma showing a reticulation is slower growing than a melanoma showing a globular pattern. So I think that may give us some clue if we do more of these studies into the biology of this melanoma arising versus that melanoma arising in a nevus. Not all melanomas arising from nevi, you can clear-cut, differentiate the nevus component from the melanoma component. We recently researched that, and in many of these melanoma-associated nevus, the best clue was a negative network, actually, and it was very difficult to differentiate the nevus component from the melanoma component. On a dermoscopy, there was also Iris's work that was able to differentiate in some of these cases, these two components apart.
Yeah, I quite agree. And what I could add, I have a very interesting case some years ago when a resident of mine came to bring a case that was from a patient very close to her. And she was saying, I'm following this lesion for around 5 years, and it is enlarging very slowly. And I'm looking for dermoscopy, and we have only a very slight, a very regular network. This patient, she had already 2 previous melanomas. She was around her 50s. And she came to me when she noticed, as Zoe said, the island sign, some small globules on just one spot from this large regular network lesion, reticular lesion. And so we were a bit confused because, I mean, I was not following this patient, but it was very clear that they were new structures. So, of course, we decided to biopsy, but the lesion was very large and the patient did want to remove it. So it's not exactly what we know that it's maybe the standard of care, but we decided to do an incisional biopsy in this new structure, and it confirmed to be a 0.3 superficial spreading melanoma. And of course, the lesion was then removed, and it was the whole lesion an in situ melanoma. So probably, I don't know, for several host and tumor connections, this tumor was standing just superficially, and in that specific point, it could invade, and then we could notice this dermoscopic change. So, of course, this is perhaps the main point to notice for new structures to always find those melanomas.
In my view, I agree with all of you. And of course, when we have a suspicious lesion, as Zoe and Alon and Renato mentioned, we have some clues, globules, negative network, projections, clues that can predict that this could be melanoma associated with an EBUS. I agree that sometimes globules are very striking feature. If you find globules, probably if there is something wrong, could be an invasive case, as you mentioned. But of course, I think that we need to remember that from the digital monitoring insights that we know now, or at least in our experience, more or less 60% of the melanomas that were diagnosed after long follow-up, after lesions that were completely banal, and then they were melanomas. They were not melanomas associated with an EBUS. So we still have a third possibility, and could be an EBUS that is evolutioning to a melanoma. So it's not only slow-growing melanomas, melanomas associated with a banal EBUS. We can have a third option, and this is why we need to still going on with this research, because we are not sure about that. I think there is other point, if we have enough time, it's regarding this very interesting point that Ash mentioned at the end of his talk about white structures. He mentioned, as a summary, he says that when you see, in the context of melanoma, when you see white without vessels in a flat area and without shiny white areas, this is quite a good regression, of course. And in contrast, when you see shiny white lines, vessels, and white, and more over a raised area, this is probably not a good regression. And to me, this is very interesting because, as you may know, we have done some research in Sutton nevi, and Sutton nevi not always has the white and just and that's it, the white halo. They can have also very striking features and atypical dermoscopic features, but for the pathology is a Sutton nevi, and that's all. But it's true that we usually don't see shiny white areas in Sutton nevi. So this is something that, to me, makes me think, because probably beyond this inflammatory regressive phenomena, probably we have much more information or much more data that we are ignoring, I think. No, I don't know what's your opinion.
Guys, we have 1 minute more.
Okay.
Yeah. Okay, I think that we need to make much more research in this particular sign of white areas, shiny lines, and so on. We should not forget that also in situ melanoma creates these white structures, shiny white structures, and this is relevant to regression too, because even though in situ it can trigger inflammatory reaction, the melanoma, and this is why this goes on with the creation of fibrosis and so on. So even if it is in situ, we can still see white structures in dermatoscopy. If anything particular of all these structures described in this under this spectrum, let's say, of criteria, of white criteria, I think that we still need to research more in this field.
Yes, probably we are waiting for molecular answers. And when we see that white lines, we see also in not only melanomas, but also in basal cell carcinomas, and Spitz nevi, always lesions that are always dangerous, or at least we need to take some care, probably there might be a connection. I think it's very interesting, the theory, and I'm looking forward for this molecular analysis.
So I think we need to close the session. It was a pleasure, and enjoy the rest of the meeting. Bye.
Thank you, everybody.
Bye.
Bye.
Thank you.
Thank you.
Ahora subimos acá. Ok, bye.
Because it is our duty to do our bit. Every time we care for a single person, we make the whole world better. because it is our duty to do our bit. Every time we care for a single person, we make the whole world better.
Hello. Today I will be talking about some not so obvious aspects of trichoscopy. In most cases, we use trichoscopy in clinical practice to diagnose hair and scalp diseases. This is only one of the applications of trichoscopy. We can also use trichoscopy to monitor the progress of the disease or the efficacy of the treatment. We can use it to predict treatment efficacy and as a diagnostic tool beyond hair loss and sometimes beyond hair and scalp diseases. Let me start with an example of how we can use trichoscopy to monitor treatment efficacy. One of the examples is using trichoscopy to monitor the efficacy of treatment of tinea capitis, and in the left image you see the typical trichoscopy features of tinea capitis, and in the right image after treatment they disappeared. When monitoring a patient with tinea capitis, we will look mainly at the most typical, the most characteristic trichoscopy features, which are the comma hairs, the corkscrew hairs, and the other typical trichoscopy features of tinea capitis. However, it may be also valuable to take a look at the features which are not so specific, but they are very common in tinea capitis, such as the broken hairs, the black dots, or the scaling. And while we are treating the patient, we wait for the moment when all these typical trichoscopy features are gone. However, it is important to remember that negative trichoscopy does not mean that the patient is cured. Negative trichoscopy has some predictive value, but still we need to have a negative mycology culture to confirm the disappearance of the fungus. When treating and monitoring a patient with tinea capitis, it is important to remember that trichoscopy and the mycological culture are two methods which are complementary, and in my opinion it is a mistake to just use one of these methods in monitoring of treatment efficacy in patients with tinea capitis. This was an example how we can apply trichoscopy to monitor treatment efficacy, and now I would like to show an example of how we can use trichoscopy to predict hair regrowth in a patient with hair loss. My experience show that in patients with hair loss, with various diseases which lead to hair loss, that pre-treatment trichoscopy may have a limited value in terms of predicting hair regrowth. And this is also a case in alopecia areata. Here you see two images, one a field of view full of yellow dots, the other one with multiple black dots and exclamation mark hairs. And we are not able, based on these pictures, predict whether or not the patient has a higher or a lower chance of hair regrowth. There is the alopecia areata predictive score, which allows predicting to some degree the chance of a hair regrowth in a patient with alopecia areata. We perform it at the margin of the most recent patch, and it has been shown that the best time to perform this examination is after 2 months of treatment. The alopecia areata predictive score is based on the division of typical trichoscopy features of alopecia areata into two subgroups, into the ones which have a negative predictive value, such as the exclamation mark hairs, the tapered hairs, the black dots, and the broken hairs, and the ones which have a positive predictive value, such as the upright regrowing hairs and the pigtail hairs. Based on this data, it is possible to calculate the probability of hair regrowth in a patient with alopecia areata if the treatment remains unchanged. This is an example of a trichoscopy image in a patient who was treated for alopecia areata with corticosteroids for 2 months, and here we can look for the positive and the negative predictive trichoscopy signs. On the negative side, we will see some black dots, which gives a -1, and the broken hairs, another one -1. And on the positive side, we will see some upright regrowing hairs. So this gives together a -1 score, which is associated with the probability of hair regrowth of 2%, which means that we should consider changing the treatment. So we can use trichoscopy for diagnosing the cause of hair loss, for monitoring treatment efficacy, for predicting hair regrowth. And now I'd like to show you some examples how trichoscopy can be used beyond hair loss. I would like to start with a topic which is often neglected at conferences, but it is very common in clinical practice, and I was inspired by this great article by the group of Antonella Tosti about the scalp itch, and especially about the red scalp syndrome. Not always the scalp itch is associated with the red skin, but in some cases it is. And here trichoscopy can be helpful to identify the cause of itch in these patients. The authors list over 40 different causes of scalp itch, with these ones being the most common ones according to the literature. And I believe that this may depend partly on the geographic area and on how many children we are seeing. In my practice, the 3 most common causes of scalp itch are seborrheic dermatitis, lichen planopilaris, and psoriasis. And it is important to distinguish the itch from the paresthesia, which the patients may experience when they have androgenic alopecia. This is a patient who visited my office just recently. She came in with very intense scalp itch, and if you take a look at trichoscopy, what is mainly visible are multiple broken hairs, some interfollicular blood vessels which may indicate an inflammatory process, but most importantly, we see multiple short hairs in a bushy-like appearance, and this is the typical feature of scalp dysesthesia. And this was our diagnosis, later also confirmed with histology. This is another patient with a history of itch. Actually, she visited my office because of the hair loss, and the itch was not her main complaint. Over the time, she was using multiple over-the-counter vitamins and topical drugs, but she decided to see a dermatologist because these treatments were not effective. And I performed trichoscopy. Trichoscopy may have been a little bit surprising. There were no features of androgenic alopecia. There may have been some features of telogen effluvium, such as multiple units with only 1 hair. But what especially caught my attention were the multiple elongated and enlarged blood vessels. So what came to my mind was the possibility of a connective tissue disease. I asked the patient to perform some lab tests. She had proteinuria, a low white blood cell count, and positive antinuclear antibodies, and so she fulfilled the criteria for systemic lupus erythematosus. So in this patient, the hair loss was the first clinical sign of a systemic disease. Just as a reminder, in lupus, we can expect discoid lupus erythematosus on the scalp, which will result in cicatricial alopecia, but there may be also non-cicatricial alopecia in lupus erythematosus, and it may have different forms. The diffuse form, which is sometimes mistaken as an androgenic alopecia or a telogen effluvium of another cause. Sometimes a focal alopecia, which may look a little bit like alopecia areata, or the so-called lupus hair. One other example how trichoscopy may be helpful in identifying the causes of various diseases. This is an article from our group from just recently, which has shown that in patients with erythroderma, you may suspect the cause of erythroderma on the basis of trichoscopy. So to summarize, trichoscopy is a major diagnostic tool in identifying the cause of hair loss, but also it can be helpful in monitoring treatment efficacy, in some cases for predicting hair regrowth, but also for diagnosing diseases beyond hair loss and sometimes beyond dermatology. With all my enthusiasm for trichoscopy, it is important to keep in mind that this is just one of the tools in the hands of the dermatologist, and there are now multiple data piling up showing how it can be useful in clinical practice. However, I believe that time and more data are needed for some aspects of trichoscopy to be confirmed. If you would like to hear more about trichoscopy or about hair diseases, please consider taking a look at my YouTube channel. Thanks a lot.
Hello to everybody, and today I'm going to discuss some tricks that are important in trichoscopy. So this is a list of things that I really believe you have to follow, okay? So first, always examine the patient with dry dermoscopy first. So this is very important to prevent, don't make important diagnosis. So you have to examine with a contact dermoscopy without interface solution or with polarized light. Why? Because you want to be able to see the scales that are an important feature for some scarring conditions. Here you see we look for peripylar casts. Of course, you don't have to look for interfollicular scales. Interfollicular scales are not so important. What's important are these scales that surround the hair at its emergency. These casts that I call peripylar casts disappear if you use the interface solution. So this is the same area you see, you don't see the cast anymore. And so you will miss some possibly important diagnosis. So when you have to be concerned, you have to be concerned when you see casts that surround a tuft of hair, okay? As here, as here, as here. And you also have to be concerned when you see pili torti, as both peripylar casts and pili torti are very common in scarring alopecia. Pili torti not only in primary scarring alopecia, also in secondary scarring alopecia. And here you see this case, you see the hair shaft variability, you should see the peripylar casts. You can know this is a case of fibrosing alopecia in a pattern distribution. And so you can make the diagnosis. Second, when you have a patient like this, that you think she may have frontal fibrosing alopecia, as there are no vellus hair at the hairline and you see some peripylar cast, but you want to make the diagnosis, you have to take a biopsy. Think that this is a very cosmetic sensitive area. So if you take a 4 millimeter scalp biopsy, this patient will get a scar in the area that it's for her the most important. So you have to take a very small biopsy. And you can use trichoscopy to select this 2 millimeter punch biopsy in the hairline or from the eyebrows. And you have to tell your pathology to read this paper that explain you how can you make the diagnosis using these very small samples. It's very useful to use high magnification to assess variability, because it's much easier to see variability at a higher magnification than a lower magnification. You see here that hair have different thickness, and you can use this image to assess the percentage of variability. So if you have a normal instrument, you just take a picture through the dermatoscope with your phone, then enlarge the screen on the phone, and you can reach the high magnification. So you don't need a special instrument for that. So be careful when you look for vessels not to apply too much pressure. You see the same area without pressure, with pressure. With pressure, the vessels fade, particularly the arborizing vessels. Again, you see them fading. Instead, the twisted capillary loops do not fade. This is another way to distinguish these two different types of vessels that are a sign of different conditions. When you have to inject in inflammatory alopecia or in alopecia areata, use dermoscopy to check the area. You need to inject where is needed, not where is not needed. For instance, here in alopecia areata, you want to inject this area. Here, this is definitely an area to inject. This is not an area to inject. So it's very important to evaluate inflammation that correspond to thickness of peripylar cast and inject where is needed. It's very important to use dermoscopy to explain the disease to the patient. This is very useful to increase compliance. So I always take a picture and I show the picture to the patient. You can take a picture in a big instrument. You can take a picture with your phone, doesn't matter. Again, as I said, you can just take the picture with a phone through the dermatoscope. So, and use the picture to show variability, for instance. This is very important because patients have to understand that the number of hair is not changed, that it's just the thickness, and we want to increase the thickness, and of course, it will require time. And, in patients with telogen effluvium, if you show them the new hair growing back, that is very, very important, because some of these patients believe their hair will never grow back, they will get completely bald. So use this image. This will reassure the patient a lot. And even in alopecia areata, if you show them the yellow dots so that the follicles are still there, they feel much relieved, because they think the follicle may have died, may have not been there anymore. And the same in alopecia areata, if you can show them the new hair regrowing, means a lot to the patient, because this can be seen before it's visible with the eye. And you can use the dermatoscope to establish short-term prognosis and for establish a response to treatment. For instance, in alopecia areata, if you see that the normal scalp has this feature, you can tell this patient that the disease is going to get worse before improving. And again, here the normal scalp has this pseudomonolectric hair. This means, that the disease is progressing, and the patient may develop new patches. And in case of lupus, for instance, if you see these red dot patterns, that means that the hair can regrow. So you need to be aggressive with the treatment here. And you can see the hair can regrow completely in discoid lupus. And of course, follow-up during treatment. Here is lichen planopilaris. You see the cast disappear, mean that disease is responding. And then be aware of pitfall. So you can see scalp deposits, staining, hair shaft deposits. You know, these are very common. People use camouflage products, and you don't have to misdiagnose these as dermoscopic features of other type. These are not broken hair. These are just fibers. And staining is very common either with semi-permanent and permanent dye that often penetrate the follicle. And here, for instance, is my patient with alopecia areata who just had an hair dye, and these are just the dye. It's not black dots showing active alopecia areata. And the same for anthralin. Anthralin very typically stain the orificial openings. And this is, again, you see this permanent dye may look like a peripilar sign. No, it's just staining from dye. And so also be aware of this society, the International Society of Trichoscopy. You can become a member for free and just email me if you are interested in that. And to finish, this is the World Congress of Trichoscopy that is going to be held in person in Sorrento in the beginning of October, 9 to 11. And I hope that you will be able to come. Italy is open now, and I really hope we will be going to have a very successful meeting. Thank you very much.
Hello, I'm Sergio Baño from Madrid, Spain, and it's my pleasure to participate in this virtual World Congress of Dermoscopy. Thank you very much to the organizing committee for the invitation. I'm going to talk about how to assess treatment response in hair loss disorders with trichoscopy. Well, this is my slide of disclosures. And first of all, I like to start with this sentence: trichoscopy is to hair disorders what dermoscopy is to pigmented lesions. So it's an essential tool in the diagnosis and in the monitoring of almost all hair disorders. And we're going to talk over the lecture about these two topics, how to assess treatment response in hair loss disorders with trichoscopy in non-cicatricial alopecias, specifically in androgenetic alopecia and in alopecia areata, and we will discuss also how to assess treatment response in cicatricial alopecias. Well, let's start with non-cicatricial alopecias, and first of all, we can monitor the treatment response in a clinical way in cases in which the treatment is really effective, like in these two cases of a 34-year-old male with androgenetic alopecia treated with oral dutasteride and topical minoxidil with an excellent response after 12 months, or in the case at the bottom of this 28-year-old male with treatment with dutasteride and oral minoxidil and mesotherapy with dutasteride. Well, we don't need a trichoscopy to confirm that it has been an improvement in these cases, but there will be other cases in which a trichoscopy will be essential to monitor the treatment response. We can summarize in this slide the different methods, trichoscopic methods to monitor treatment response in androgenetic alopecia. The basic one is the comparison of trichoscopic images, and the advanced one are different softwares that allow the comparison of different trichoscopic parameters between visits. We can distinguish the Folliscope 1, the hair metrics of Canfield, and some tools from PhotoFinder. We will discuss about them in the next slides. Well, this is a very interesting article recently published in the Blue Journal regarding a very easy way to monitor trichoscopic pictures in patients with androgenetic alopecia. They propose to perform these images in 5 points in the frontal area, 10 centimeters above the glabella, the left and right temporal, 10 centimeters above the ear, in the vertex, in the line that crosses the perpendicular line between the both ears and the medium line, and the occipital one 3 centimeters above the occipital protuberance. This is a very easy way to monitor patients with androgenetic alopecia. Well, this is another interesting article from the group of Dr. Rod Sinclair, in which they propose a trichoscopy-derived Sinclair scale that correlated closely with the clinical Sinclair scale. And in fact, in this trichoscopic scale, the cumulative hair thickness density correlated very well with the clinical Sinclair scale. So this is a very interesting way to correlate the different degrees of androgenetic alopecia in the Sinclair scale with the trichoscopy-derived Sinclair scale. Well, let's see the two most advanced, in my view, methods of monitoring the changes of treatment in androgenetic alopecia. This first one is the hair metrics tool from the Canfield company, and this artificial intelligence-driven and clipped hair analysis consultation can compare the different parameters like terminal vellus ratio, the average hairs per follicular unit, the average hair width, the hair follicles per square centimeter, and the interfollicular distance. And we have the other tools from Photo Finder, the Tricolab, and the hair-to-hair matching that tracks individual hairs along the time of the study, and it can measure all these parameters, and they are especially useful not only for clinical studies, but also for some cases in clinical practice. Well, what about alopecia areata? These are the trichoscopic signs that are useful for assessing treatment response. We have signs of activity like black dots, exclamation mark hairs, broken hairs, taper hairs, or the pseudomonolectrics. And we have signs of hair regrowth like these pigtail hairs or vellus hairs that can indicate that the treatment is effective. So as in this study is stated, we can see how trichoscopy can help in the evaluation of the efficacy of alopecia areata treatments as well. So we have seen that trichoscopy is very useful in the treatment monitoring in patients with androgenetic alopecia and in patients with alopecia areata. What about cicatricial alopecias? Well, in cicatricial alopecias, we can monitor the treatment response in several ways. We have to monitor the clinical hair loss, the inflammation, and also the symptoms. But we can use trichoscopy to monitor the improvement in the inflammation and also to monitor the improvement in hair density. There are other methods of measuring these different parameters, but we will focus on trichoscopy. Well, in frontal fibrosing alopecia, a very easy way to monitor inflammation with trichoscopy is this easy scale of 3 degrees of inflammation: no inflammation, a mild inflammation, and severe inflammation. We can see on trichoscopy the typical trichoscopic signs of FFA, which are perifollicular erythema and especially peripilar scales. In fact, in this nice study about a frontal fibrosing alopecia severity index with trichoscopy, it was described that the severity of peripilar casts was correlated with the degree of lymphocytic infiltrate. So this is very useful in clinical practice. We can monitor the treatment response. If we see an improvement in these peripilar casts, we will decrease the activity of the disease. Well, what about lichen planopilaris? This is a case of my friend, Dr. Angela Hermosa, of a 59-year-old woman with LPP, and she was treated with oral minoxidil 1 milligram daily and topical clobetasol twice weekly. And we can observe that after 6 months on trichoscopy, there's an improvement in hair density and a decrease in the peripilar cast and the inflammatory signs. And in this other case of LPP treated with platelet-rich plasma and intralesional triamcinolone, we can also monitor with trichoscopy this improvement in hair density and this decrease in the inflammatory signs. Well, in the third most frequent type of cicatricial alopecia, folliculitis decalvans, I have to highlight this study of Dr. David Saceda regarding a trichoscopy activity scale for folliculitis decalvans, in which he described these different degrees depending on the trichoscopic features, and we can classify the patients with folliculitis decalvans and the response of therapy depending on this scale. So there are several groups: group 0, no activity; group 1, slight activity; group 2, moderate activity; or group 3, intense activity. And we can monitor the treatment response depending on this scale. For example, in this patient, we can see pastels, perifollicular erythema, CRAS. The trichoscopic activity scale is higher than 3. We started a treatment with clindamycin plus rifampicin and intralesional triamcinolone with a great improvement after 3 months, in which we observed on trichoscopy that there were no signs of inflammation and the Well, we have seen how trichoscopy is very useful in the assessment of treatment response in patients with different types of cicatricial and non-cicatricial alopecia. So as conclusions of my lecture, I have to say that trichoscopy has become an essential tool in the diagnosis and follow-up of different hair disorders. In non-cicatricial alopecia, trichoscopy may be used to monitor treatment response. In androgenetic alopecia by direct comparison or quantification by complex softwares, and in alopecia areata, trichoscopy can help in the evaluation of the efficacy of treatments by the assessment of the different trichoscopic signs of activity in this autoimmune alopecia. And in cicatricial alopecias, trichoscopy is useful to assess treatment response related to both hair density and inflammation, and there are different validated trichoscopic scales that might guide the clinician in the management of patients with frontal fibrosing alopecia as well as with folliculitis decalvans. Before finishing, I want to remind you that the World Congress for Hair Research will take place in 2022 in April in Melbourne. I'm looking forward to meeting all of you here, and I hope that this lecture has been useful for you. Thank you very much for your attention.
Good day. My name is Sergio Hirata, and today I will talk about the management of melanonychia. The first question is, when should nail plate dermoscopy be performed? The answer is always. In all cases of melanonychia striata, that's because clinical criteria are not always precise, such as in these similar looking lesions, where we have only 3 cases of melanomas. The nail plate dermoscopy is based on the analysis of background color and longitudinal line regularity. If we have a gray background, we have drug or racial pigmentation. If we have brown background with regular lines, we have melanocytic nevels. And if we have the same brown background, but with irregular lines in color, width, or parallelism, we have melanomas. So, to sum up, if we have regular brown pigmentation, we have benign lesions, and if we have irregular brown pigmentation, we have malignant lesions. And when should we perform dermoscopy in the nail matrix? Only in dubious cases, such as in these lesions, when it's not possible to safely establish the pattern of nail plate dermoscopy. We know there are limitations with nail plate dermoscopy, such as in these examples, where we have 2 cases of melanomas showing brown background with regular lines. And why do we have limitations with nail plate dermoscopy? We know dermoscopy has advantages over clinical examination, but these advantages are greater for skin lesions than for the nail plate. That's because when we examine the nail plate, we are not visualizing the lesion at its site of origin, that is the nail matrix. So, to solve this problem, in difficult cases, we propose the use of nail matrix dermoscopy. It's a fast, easy, and low-cost method that provides additional information. It is an intraoperative procedure, and the use of polarized light dermoscope enables examination of the matrix with no contact with the tissues nor surgical drapes, thus avoiding contaminations. And what is the importance of intraoperative dermoscopy? As we can see in this table, it's easier to make a diagnosis examining the nail matrix as compared to the nail plate or based on clinical features, despite the experience of the examiner. And how is nail matrix dermoscopy performed? You have to do a distal or proximal nail avulsion. If you want to do a proximal nail avulsion, first you have to detach the proximal nail fold, then expose the proximal portion of the nail plate, and then detach the nail via proximal approach using delicate instruments such as this dental spatula. And after nail avulsion, dermoscopic examination is performed directly on the matrix, and the lesion is classified according to the pattern found in benign or malignant. And what are the dermatoscopic patterns of nail matrix? The first pattern is the regular gray pattern. It's composed of fine and regular grayish lines, and it is common in melanocytic activation. As we can see in this picture, it is much easier to see the regular pattern at nail matrix compared to nail plate dermoscopy. The second pattern is the regular brown pattern. It is composed of regular brown lines, and it's most common in benign melanocytic hyperplasia. Again, it's much easier to see the regular pattern at nail matrix compared to nail plate dermoscopy. Another pattern is the regular brown pattern with globules or blotches. It is composed of fine and regular longitudinal brown lines and presence of globules or blots with regular size and distribution, and it is common on melanocytic nevus. And the last pattern is the irregular pattern. It is composed of longitudinal lines of irregular color and thickness, presenting irregular globules or blotches, and it is common in cases of melanomas. So we can see it's much easier to see the irregular pattern at nail matrix compared to nail plate dermoscopy. So when we do matrix dermoscopy, if we have irregular pattern, we can perform an excisional biopsy. If we have a regular pattern, we can perform a shave biopsy. The shave biopsy reduces occurrence of nail dystrophy. And if we have a regular gray pattern, we can just follow up the lesion. Here we have a suspect case, but matrix dermoscopy shows benign pattern allowing for follow-up or shave biopsy. Here we have a dubious case, but matrix dermoscopy shows a suspect pattern allowing excisional biopsy. And here we have a case in children. The dermoscopic examination of the matrix shows an irregular pattern compatible with malignant lesion, a melanoma. So in this case, we can choose to do an excisional biopsy. Here's to show the difference between a regular pattern in a melanocytic nevus and an irregular pattern in a melanoma. Here we can see the regular distribution of globules, and here we can see an irregular area. So benign and malignant lesions may have similar clinical and dermoscopic findings, and sometimes it is difficult to make the differentiation. But nail matrix dermoscopy enables a differential diagnosis. Here we have a typical hyperplasia, and here we have a melanoma. So how is the management of melanonychia? We always do a clinical evaluation and nail plate dermoscopy. If it is regular, we can just follow up the lesion. If it is irregular, we can perform nail matrix dermoscopy. If it is regular, we can perform a shave biopsy or just follow up the lesion. And if it is irregular, we can perform an excisional biopsy. Thank you.
And start the discussion. Good luck. And thank you.
Thank you. Thank you.
Thank you.
And start the discussion. Good luck. And thank you.
Thank you. Thank you.
Thank you.
And start the discussion. Good luck. And thank you.
Thank you. Thank you.
Thank you.
And start the discussion. Good luck. And thank you.
Thank you. Thank you.
Thank you.
Discussion. Good luck. And thank you.
Thank you. Thank you. Okay, we're live. Hi, everybody. I have a pleasure to have with me Professor Lydia Rudinica. Professor Antonella is not here, but she gave a lecture to get in. Professor Sérgio Vanho, Professor Sérgio Hirata, Professor Luis Sanchez, Professor Micaela Starassi, Professor Masaru Tanaka, and Professor Balachandra from India. Okay. Hi, guys. It's a pleasure to have in this new form of congresses, but what we can do it. And we have someone have to talk something, to say something, Professor Lydia.
Yes, first of all, thank you for the invitation and thanks for having this session. I think I'm really very happy because I think this is one of the first congresses, dermoscopy congresses, which has a trichoscopy and onychoscopy session. Actually, the first one was in Thessaloniki. Now it's, I think, the second occasion. So it's good that hair and scalp dermoscopy and nail dermoscopy is part of the major field of dermoscopy right now. Really like
the internet from Lydia. Lydia? Okay. Sergio, want to talk something to us?
Hi, Leo. Thank you very much for the invitation and congratulations to all the speakers because there has been interesting lectures and we are looking forward to listening to the questions of the audience.
Okay. And Professor Masaru, want to talk something from Japan?
Yes. Good evening. I'm from Tokyo, Japan, and it's 11 o'clock in the night, and I'm a little bit sleepy because I always sleep before 10 o'clock, and so and this is the first day, and I'm not accustomed to the time in Europe now.
Yes, in Brazil
I
is
really
morning.
enjoyed it.
And you, Professor Balachandra, please talk from India.
Yeah, I'm from India, and now time at India is 7:50 p.m. So still go to there, and I'm very happy to be a part of this panel, which is filled with experts in anicoscopy and trichoscopy. Thank you very much.
Okay, I will talk. We have one question from the audience. I think Professor Balachandra can ask. We are discussing in the WhatsApp chat. What is the histology features of scalp dysesthesia? And then Lydia can comment as well.
Yeah, as I texted in the WhatsApp, so it's basically a prurigogenic stimulus and response to the chronic pruritus, that scalp dysesthesia, and it shows epidermal hyperplasia in the form of elongation of parietal ridges as well as hyperkeratosis, and there can be basal layer hyperpigmentation can be expected. And since it's chronically itchy, so we expect collagen bundles to be arranged in a vertical pattern in dermis, and some nerve tics can be seen in there, and there is a mild to moderate infiltration because of inflammation. So these are the characteristic of scalp dysesthesia. And I think Dr. Lydia has one paper on trichoscopy of scalp dysesthesia, which easily differentiates from other itchy scalp conditions, I think.
Yes, this is actually the article of Adriana Rakowska, my coworker. We did it as a team, and yes, it is maybe for those of you who are not very familiar with this, it is worth just repeating that it's not a disease in itself. What we see in trichoscopy and in histology, this is the effect of scratching. And sometimes the patients are scratching their head for many hours a day, and sometimes during the night, even without knowing this. So in trichoscopy and scalp dysesthesia, we will see some non-specific features such as the broken hairs, sometimes the black dots, but what is quite characteristic is this bushy type of hair with multiple fibers which develop when the hair is scratched and it is consequently destroyed, or the hair shaft is destroyed. It will break into multiple fibers, and this makes the impression of this bush-like appearance.
Okay, great. And Professor Lydia and Sergio, someone want to answer, which is the concentration of the triamcinolone that you inject in lichen planopilaris or in alopecia areata, because you have the paper from Professor Shapiro that they go low to 2.5, but sometimes not working. What you are using for everybody?
Yes, this is a very good question, and I wanted to ask Sergio exactly the same question because I saw it on his slide. I started using higher doses. I was using 10 milligram, and then I was using 10.5. Then I was using again 10 because I believe it works better. And I must say, if I have cicatricial alopecia, then I would use 10 or sometimes even more than 10. You know that if you use a too high concentration, then the needle gets clogged, so you cannot use a concentration too high, but I am somewhere between 10 and 24 for cicatricial alopecia, especially for lichen planopilaris. For alopecia areata, it will depend. If I have a very young person who is likely to have atrophic reaction to triamcinolone, then I would use a lower concentration of approximately sometimes 5, sometimes 10 milligram. In an adult or modern or elderly person, I would use more. But maybe what I would like to mention also, I started using triamcinolone more often than just every 4 weeks. I started believing that every 4 weeks may not be sufficient for every patient. So this is my experience, but Sergio, I would be happy to listen to what is your opinion.
Yes, of course, Lydia. Well, it's a very important issue. I read the recently published meta-analysis that showed that probably 5 milligrams per milliliter was the most effective and safe dosage. But in my experience, I agree with you that we use higher doses, especially in alopecia areata, and depending on the location of alopecia areata, for example, for psoriasis, we use 10 to 12 milligram per milliliter, and the median dose that we use is probably 8 milligram per milliliter. In lichen planopilaris, it would depend on the location and also on the thickness of the peripylar casts, and we treat with concentrations between 4 and 10 milligrams per milliliter.
Great. And
how about the other ones? Maybe let's. I don't know. I don't want to take your job, but Leonardo, how do you do it in Brazil?
Professor Lydia, you are very welcome. And Professor Balachandra, you use triamcinolone to infiltrate?
I do use, and sometimes I use 10 milligram per milliliter, and whatever concentration of the drug, I believe that that area to be injected should be measured. So whatever amount of the concentration of the drug, but area to be injected has to be measured. For example, 10 milligram per ml triamcinolone should be injected 0.1 ml per square centimeter. That is this thing, according to my experience.
If I can say something, I use the same concentration in always, but the difference is how many liquid you inject in my experience. So I didn't any difference in the patient, and also I decide the time to inject again, different. For example, in alopecia areata, I usually every 45 days, so 1 month and a half. In lichen planopilaris, I wait 2 months, usually. It's the same, for example, in when I inject in nail disease. I have the same dosage, but in the different time. In psoriasis is more frequently, in lichen planus is with the height time for each session.
Yeah, I was asking for nails because I don't have any experience. Professor Hirata can talk about nails injection.
I usually use triamcinolone.
And the concentration that you use to nails?
1/3.
Okay.
Yes, the same also for hair. I use triamcinolone, but also in psoriasis I use methotrexate.
Yeah.
Nice. Leo, may I ask a question to all the speakers? Do you use any type of anesthesia before injecting, for example, intralesional triamcinolone for alopecia areata or lichen planopilaris?
No.
Only ice.
Yes, I do. I use a little bit of ethylene chloride, but just very soft, not to make the skin hard, but this improves the comfort. And also it allows me to make the injection.
But you put the anesthesia into the triamcinolone or no?
No, I have it in the form of a spray. So I spray over the area, but just very slightly, not, because if you spray too much, the skin will become hard and then you cannot make the injection. So I just make a very, very slight.
I use a vibratory anesthesia. Can work sometimes.
Same of Lydia. I use a bandage and then I put the bandage on the scalp. While in the nail, I use a direct, but very far, not so, because it is avoid the burn, iceberg.
Someone to talk, Luis?
Sergio?
Well, I have 2 little tips. The first one has been already said by Leo, which is to use a vibration device. And the other one is that in extend areas to inject, we can do a truncal anesthesia or block the frontal hairline and the rest of the scalp until the crown will get anesthetized. It's very useful.
Yes. I mean, I'm used to do a truncal anesthesia here or over the hairline and over in the back. Works very well. Even to do microneedling. Michaela have a great experience with microneedling, and I do this to microneedling. Professor Tanaka, do you have any experience with the some anesthesia to improve the pain of the patients?
Yeah, I think it's greatly depends on the cases, and in patient with melanonychia, I always use digital block with 2% xylocaine.
Okay. Yeah. Luis, do you want to talk something?
Yes. Hi, everyone. It's an honor to be here, and hello to everyone. I would like to ask you if you use only saline solution to make the dilution of this triamcinolone, because I find that for us it's very difficult to do it with saline solution, because then the mix is crystallized and it's so difficult to inject, and we miss some syringes because it's crystallized and we need to change during the session. So first I use this, as Dr. Rudnicka said, this topical anesthetic 10% lidocaine that it's made for mucose. We use it for the scalp, and we use some plastic to do it occlusive, like 20 minutes before the injection, and it's so effective in that way. And we use this lidocaine 2% solution without epinephrine to make the dilution. So then I have the anesthetic in the mix, and is not crystallized. But I don't know if you use this type of solution to make the dilution of triamcinolone, because for us, saline solution that it's reported in all the papers is not working for us.
I can start because it's a really interesting issue, and I totally agree with Liz that we don't have good experience with saline solution, and we use 2% mepivacaine to do this mixture. It's easier, and perhaps even in extended areas, it can decrease the pain of the injections.
I already read that if you use some anesthetics with conservants like formaldehyde or other ones, they can crystallize the solution of a triamcinolone, because this is not a solution, it's a suspension, and then they can block, and maybe in this way can make more atrophy. I'm concerned about using not the anesthesia, but the conservants that there is in anesthetics. But if you compound anesthetics without any conservant, maybe you can use. They put this on the Hi, Antonella.
Hi, Leonardo. I'm here, even kind of strong situation. Okay.
Yes, we are in. Okay. Antonella, tell us about we are talking about to inject in lichen planopilaris and alopecia areata. Tell me your experience with the concentration and what you use to dilute the triamcinolone.
I use saline, and I do 2.5 in alopecia areata, and I do 5 milligram in lichen planopilaris usually.
Maybe we can ask, Leonardo, sorry, maybe we can ask if there are people listening to us, maybe we can ask everybody who is listening to write in the chat, what is your experience? How do you dilute triamcinolone and how do you inject?
Yeah. Okay, the chat is here if you want to make up questions. Professor Lydia, the word is you can talk about the one question to the audience or for us.
Yes, I have a question to everybody in the panel. Still staying with triamcinolone, how much do you use per one session? Do you use 1 milliliter, meaning 40 milligram? Do you have any rules for this? Do you use more than 1 milliliter? What is your experience and your approach in terms of the total volume injected per one session?
Well, it's a very interesting issue. I try not to go up of 40 milligrams per session, so 1 milliliter, because in some of my patients with diabetes, they have seen an increase in the sugar, in the blood levels of sugar, after sessions with a higher amount. So I try to be below 40 milligrams.
Yeah, the same. If I want... sorry, if I want go to have a systemic action of the triamcinolone, I go up to 40. But if I want to go lower, I can, if not have a systemic action, I go up to 20, 30 milligrams in total. But in some case of alopecia areata that we are not doing nothing and we can have nothing to do. And during the pandemic, I did injections in the whole scalp with 40 milligrams, 1 milliliter, and these are working great. It's a very good tip.
But I believe if at that point you can give intramuscular, it's the same, Leonardo, and maybe it's less painful for the patient.
Yes, but sometimes not working in the intramuscular, and when we are injecting the scalp, they work better. I don't have the two groups, but yes, you are right. Yes, you are right. Luis?
Yes, I have a question for all the professors here in this panel. How do you proceed when you have only inactive signs of alopecia areata, for example? Do you go lower in the frequency of the injections? Do you go lower in the dose, but you keep using the injection? How do you proceed? Because then when I intend to continue injecting, I only see maybe the effects of the steroids injected or topical, but I still see the inactive signs. But it's a frequent question for me that I only have the inactive signs of alopecia areata in trichoscopy. How do you proceed?
This is a difficult question. I think it also depends whether a patient comes to my office and the patient has patches which are stable over multiple months, or whether they became stable on treatment. But if I have doubts, sometimes I would perform a biopsy, and if there are inflammatory infiltrates, I would go on with either immunosuppressive treatment or triamcinolone. But if there are no inflammatory infiltrates, then I believe that I have no chance for regrowth or for efficacy with steroids or with immunosuppressive treatment.
I use a lot of oral minoxidil in alopecia areata now, and in the US, everybody is using a lot, and that might be a good option for this type of patients. You go with oral minoxidil, and you know, the inflammatory infiltrate, sometimes you don't have a big inflammatory infiltrate in alopecia totalis universalis, and they may respond to JAK inhibitors, to oral minoxidil. You know, I think it's important, but it's not, you know, 100% sure.
Do you think, Antonella, that oral minoxidil in monotherapy can work in alopecia areata?
I don't use in monotherapy usually. You know, I combine always everything. I think you too, except for clinical trials, I don't do any monotherapy.
That's true, yes.
Sorry,
I do the same.
Sorry.
Yeah, I second the opinion of Dr. Tosti and Dr. Lydia, but when there is no signs of activity of alopecia areata, there is no need of giving injection. So better to leave it alone or change the modality of treatment as told by the experts.
Antonella, you go first.
I didn't understand the question exactly. I think it was a statement, not a question.
True.
I agree.
May I ask another question regarding injections in alopecia areata? Do you have any experience with intralesional cyclosporine?
No.
Because I received some comments on social networks regarding this treatment, and I have never seen it published in PubMed, so just to know. Thank you.
Yes, I see.
Now, there is this lady in Brazil who is, this is a different topic, but it just came to my mind, who was saying that she has very good results with intralesional bleomycin, which I also have never used, and I know that it was going to be published. I'm not sure whether it was already published, but for some, in desperate cases, sometimes maybe it may be.
But for
or scarring or like a planoparesis?
Yeah, I think the beginning was with frontal fibrosing alopecia, and especially with the eyebrow area. But then there was a case also shown at the conference with alopecia areata.
I have used bleomycin in micro needling with drug delivery that you use a tattoo machine. And with bleomycin, I already showed for you, Lydia and Tonella, in past. But
not the result, yes.
I showed the case that, but okay, but it's not working really well for cicatricial alopecia. I have some patients that worsening, and I'm concerned about to do any microneedling or anything of something in cicatricial alopecia, and it's very hard to use bleomycin nowadays. We don't have many companies doing the bleomycin. It's very hard to find it. And I have a question for nails for Professor Hirata and Tanaka. Some begin melanonychia in children look really concerned when you perform nail plate dermoscopy. Have you seen the same situation when you perform nail matrix dermoscopy, Professor Hirata?
No, in melanonychia in children, congenital melanonychia, we usually see at the nail matrix an homogeneous blotch. It's different from the adequate the nervous. In congenital melanonychia, we usually see a homogeneous blotch.
Professor Tanaka?
I do not perform the nail matrix dermoscopy, but only nail plate dermoscopy. And basically, I closely follow up children's melanonychia every 6 months, and we do not have melanoma in children in Japan so far. So I'm not very sure for the melanoma in children. I don't know. I have no cases.
Okay. And for a new regular melanonychia, would the panel suggest immediate biopsy or monitoring short-term, medium-term? A new regular melanonychia, you need to follow up these guys, or you can only, if the nail plate is good, you can leave it. Sergio?
If it is a regular pattern, I usually make a follow-up in 5 or 6 months. Only if it is regular.
Professor Balachandra?
Yeah, we should consider the involvement of digits. If it is single digit, we should know the patterns of longitudinal melanonychia under anicoscopy. If it is regular intensity and uniform diameter, there is no Hutchison sign, so we should follow it up.
If I can say something to the management of melanonychia, it is important not only to see the anicoscopy. It's not the only sign that you have to consider when you approach to melanonychia. First of all, it is important to understand the history of the patient. So in children, usually the nail melanoma is very rare, so it is very rare to have it. But we have some cases, as you know, there are 12 cases published in the world. So this is very, very rare, absolutely. But in adult, if you have a melanonychia, you have first of all to consider the time of the onset. If it is a very recent lesion, you have to biopsy, especially if you not have any history that explain this appearance. I don't know, if the patient start to have an inflammatory disease of the nail, or maybe onychotillomania and other disease that you can explain this lesion, you can follow the patient. But if you have no history, if you have, I don't know, no history of trauma or any explanation, and this lesion is very recent, less than 6 months, you have to biopsy. This is my experience, and this is the guideline. In other case, if the lesion is 3 years, is not changed by time, you can follow up the patient at the beginning at 6, 8 months, then maybe every year. But it's important to add the onychoscopy to the other sign, other history of the patient, not only onychoscopy. Because I have some lesion that with onychoscopy, it is very benign, but after there is no history, no trauma, and so on, we do biopsy, and this is a melanoma.
Yes.
Also, the other sign. So it's not. Yeah. It's important to put all together the melanonychia, I think.
Okay, and getting back to injections, now the audience asked for into our eyebrows injections. Lydia, how you perform it? It's very painful. Wow.
Microphone. Of course, in the eyebrow area, I use a lower concentration, and I use 2.5. Maybe I would like to use more, but I am afraid of atrophy, which is definitely more uncomfortable when it is in the eyebrow area compared to when it is in the scalp. But maybe it is important to say one thing, that the literature shows, and this is also my experience, that if you have atrophy after triamcinolone and you stop injecting, usually it resolves by itself within 4 months. So I usually try to calm down the patient and say it will resolve over time.
Sergio, do you want to comment on this?
Yes, I agree that we should go with a lower concentration, but I usually inject with 4 milligrams per milliliter, and in some patients I increase to 8 milligrams per milliliter, and I have never had any atrophy. Fortunately, it's true that it's very important to shake the syringe before the injection to avoid different concentrations in the same procedure, but it's a really effective treatment, and I have a lot of patients with alopecia universalis, male patients that come to our consultation every 2 months to receive these injections to maintain the eyebrows. It's a very useful treatment.
Michela, you want to comment on this?
Yes, I have the same experience of Sergio. Fortunately, I not have a lot of cases of atrophy, I don't have any cases, but I think the only side effect in my experience is sometimes the libido. It's the only one, because it's possible to take some capillary. And I explained before the patient that it's possible in a few days they go away. It's important because the skin of the hairbrand is very thin, so sometimes happen. But I use the same concentration of Lydia and Sergio, so no experience. So I think it's important to not to have a good dilution, as Sergio said, and also to not have the session too near. It's important to have time from each one.
So Balacandra, you want to say something?
Yeah, I give 2.5 milligram per ml. So less.
I always use in eyebrows 2.5. I'm concerned to the atrophy, but and a tip of if you have atrophy, you can inject saline in the local, and they go faster to recover. Only saline. And Luis, you want to make a question or comment on this?
I'm using the same concentration, and I'm only to be sure that I'm injecting the how deep I need to go with the triamcinolone. I used to hold the skin into my fingers to be sure that I'm not going deeper. but basically I'm using the same dose.
Yes.
2.5.
Yes. Do you have a question, Professor Lydia? Want to make a question for us?
Question for you.
For me. Okay.
What is your first choice treatment in alopecia universalis?
My first, if the patient has a lot of, we don't have JAK inhibitors in Brazil. Okay, and then I try to do the PCP is a defensive brown, and in sometimes I like to use corticosteroids, intramuscular corticosteroids, or now I'm doing in the scalp the up to 40 milligrams with triamcinolone that I'm having a very good response. And I have a patient now. It's only one patient in alopecia areata. We can not don't talk anything about one patient, and I'm using Excimer laser 308 nanomilligram.
Meters.
Yes, and Excimer is a Excimer lamp. I don't know the name, the machine. And the patient has a heart transplantation. He had 30 years. It's a congenital heart problem, and they are using mycophenolate mofetil and cyclosporine. They already use it, and they develop alopecia areata. And now I'm using Excimer laser, Excimer lamp, and it's growing new hairs. Maybe in some cases, phototherapy can help us with when we don't have anything to do for these patients. And you, Lydia, it's a very tough question.
It's it's difficult. You know that I have good experience with cyclosporine. Usually, I would start with cyclosporine. If this is not effective after 2 months, then I would add triamcinolone. Fortunately, triamcinolone is available in my country also in the oral form. So usually I would use either oral or intramuscular. In alopecia totalis or universalis, I don't do injections because I think it's, I feel it's a too wide field for injecting, but I know that many people are doing this.
Yes, very painful. It's very painful. Maybe we can make anesthesia like Professor Vanyo talk us about us. It's much better if you do a truncular anesthesia. Someone to talk about it?
In my sorry.
No, go ahead, Michela, please.
As you prefer, it's not problem.
Michela.
I use immunotopical therapy. First of all, in Italy, better acid squares and then DFC. And sometimes at the beginning, when start alone, then we add antraline, topical antraline with a very good result. In children, we started directly with the antraline because it's important to use immunotherapy until the 4 year of. Is my first choice, universalis.
Sergio Vanyo.
Yes, just to comment, it will depend on the profile of patients because there are patients that don't want to do contact immunotherapy. And in these patients, I agree with Lydia that cyclosporine is a very good option if we don't have the opportunity to use JAK inhibitors. But the problem, at least in Spain, is that it's a very expensive treatment. It's not covered by the healthcare system. So we are using more and more oral pulses of dexamethasone 2 days a week with good results. It's a very, very cheap treatment here in Spain.
Professor Balachandra.
Yeah, first choice is cyclosporine, oral cyclosporine. As Dr. Sergio told, it's a costly treatment. It's expensive. And we use betamethasone pulse therapy, as told by Dr. Sergio. It gives very good result. And off late, we are using azathioprine. Still, it is a double-edged weapon. Azathioprine can cause hair loss itself. But sometimes, being a immunosuppressive, it is also a useful drug to consider when other contraindications are there for other two drugs.
Can I ask you? Yeah.
No,
sorry. I have a question about azathioprine. how would you estimate the percentage of patients who respond to azathioprine?
Well,
I didn't get
sorry.
Alexandre.
Madam, can you repeat the question?
Yes, how many patients respond well to azathioprine? What is 50% or 30 or 70? How many respond well to this?
It is less than 50%. It is less than 50%.
Sergio?
Yes, I would say also 40-50%. And regarding the safety profile, 1 out of 5 patients will stop the treatment due to adverse effects. It's like 20%.
But you use alone only azathioprine or with the use of also systemic steroids?
No, I use alone in some patients. We have to ask for the thiopurine methyltransferase to see the levels of azathioprine. And the problem is that it has a very slow treatment. We have to wait even 6 to 8 months to see the response. So it's a second or third line treatment, but useful in some patients.
I have a funny question, I think, to finish.
Yes, we have 2 minutes.
Visit a patient now without trichoscopy, or in my case, onychoscopy. You never visit. You always perform a trichoscopy, onychoscopy. Now it's possible without.
No, it's impossible to do the dermatology without dermoscopy. For everything, I use dermoscopy.
I think Lydia also for hair, for nail, it's impossible.
Yes, I would like to say 100%, but sometimes it's 9 or 10 o'clock, and it's a patient whom I have seen before, and and sometimes I think let's leave it out. So it happens to me, so it's not 100%.
Yes,
it's a funny question.
Yeah, I think it's 100% using dermoscopy in hair, nails, and skin is for everybody here. I think so. And thank you, everybody. Thank you for IDS supporting this very great session. Thank you for all the professors here. Thank you, the organization. It's a very nice congress. Hopefully the next one can be together in the same room, not only in the computer. It's a very, very good session. Please, Lydia, take the final words for us.
Oh, thank you very much again, and first of all to IDS for having us here and for the invitation. Thanks to Leonardo for chairing this session in this great way. Thank you to all the speakers and all the comments. I think the comments and our practice is probably most important, more important than what we learn from the books. And most importantly, I thank everybody who is in front of the screen. Thank you for watching us, and thank you for being with us, and see you soon. Thank you.
See you in person next time.
Yes. Bye. Thank you.
Thank you. Bye.
Bye.
Thank you all. Bye.
You can start.
Okay. Hello to everybody. Thanks for your kind invitation. I will try to entertain you for 15 minutes about inflammoscopy, providing an up-to-date overview. What we really can do with our dermatoscope in inflammatory skin disorders. So once we have identified the dermoscopic pattern, this may show typical or peculiar features that will lead immediately to a diagnosis, or alternatively, they can show features that are shared by different disorders. In this case, however, the differential diagnosis is narrowed down, and those disorders clinically similar but showing a different dermoscopic pattern may be excluded. So this is very important to know from the beginning. There are many disorders, inflammatory disorders, in which dermoscopy may help, especially based on these two premises. But today I want to focus on the few disorders which you may encounter in your clinical practice and in which dermoscopy may be extremely useful. Let's start with psoriasis. We all know what is psoriasis. Sometimes psoriasis may have an unusual clinical presentation, and so we need to make a diagnosis. Normally, a low magnification, those are what you can see. You need to have a very good eye to identify these small, really small red dots. This is with the 10 magnification, or these, you can also find the whitish scales. Again, here we have red dots, here you have red dots, and then we have whitish scales here. If we use higher magnification, if you works in an institution or you have new systems that allow high magnification, then the situation is completely different, because then you will see much clearly all of these regularly distributed, dilated, convoluted capillaries with a typical bushy aspect. This is something that is a pattern which is very repetitive. You cannot miss it. Here we are 150 magnification. Just to give you an idea, this is a normal skin on your right, and then on your left slide, on the left side, there is a psoriatic skin. And again, the diameter, the capillary loops is less than 25 micron here. Bush's diameter is 70 to 100 micron. What is the histopathology? We know the histopathology of psoriasis. We don't need to discuss. But what we can correlate is a hyperparakeratosis and these larger tortuous capillaries in the papillary dermis. Again, these large tortuous capillaries in the papillary dermis perfectly match with these red dots, bushy capillaries that we see here on your right side, especially with eye magnification. Interestingly, we did a study that we recently published last year in PLOS One, in which we correlate dermoscopy with horizontal histopathology. You see, this is what you see with the small magnification, with all of these red dots here. Then we identified the same area that underwent dermoscopy, and we did histology, but we cut it horizontally. So we saw all of these papillas, and we count with dermoscopy, and we count with histopathology, and there were not so much difference. The number is around 50 red dots capillary per square millimeters, which sounds okay. But then if you calculate a 5 by 5 centimeter psoriatic patch, it means that there are 125,000 capillaries, which is an enormous number supporting the very important role of the vascular pattern in psoriasis. Going on, hyperkeratosis that you see histologically perfectly match with the whitish scale that you see with dermoscopy. Don't forget that this whitish scale need to be differentiated by the yellowish scale, which are part of the diagnostic clue of eczema. So if you want to differentiate eczema with psoriasis, then remember that there will be no dots, there will be no whitish scale, but there will be yellowish scales. Again, here, another example here, another example. And normally these yellowish scales correspond histological to exudation or to serocrusts. Moving on, discoid lupus erythematosus, typical example here. Dermoscopy at regular magnification, what you can find is follicular yellow plugs, red background, white yellowish scales, tortuous irregular capillaries. Again, another example, follicular yellow plugs, which are very typically white yellowish here, scales, and then tortuous and irregular capillaries. Moving into histopathology, those are the histopathology of discoid lupus erythematosus. And again, among all the histopathological features, the one who matches are the presence histological of follicular keratotic plugs, hyperkeratosis, and telangiectatic vessel in the superficial dermis. Hyperkeratosis that you can see histologically match with white yellowish scales, as you can see here. Follicular keratotic plugs match with follicular yellow plugs. And this is another study that we have done. You see, this is the yellow plug here. And then again, we were able to do horizontal histopathology and see very artistic expression here of these keratotic plugs, how it looks at horizontal section. Finally, telangiectatic vessel in the superficially dermis perfectly match with tortuous and irregular capillaries. Moving to lichen planus, again, we all know about lichen planus, very common in our practice. Dermoscopy findings are there is light red background here, polymorphic whitish structure which correspond to the so-called Wycombe stria, and then linear roundish vessel. Again, other example of Wycombe stria here, very typical at clinical level, is linear roundish vessels. Again, Wycombe stria, linear roundish vessel. Sometimes in the long-standing disorders, you can also find associated post-inflammatory hyperpigmentation, as in this case, and also evident at clinical level. Again, this is all the feature you can find at histopathological level, but the one who may found a match with our dermoscopy finding are these wedge-shaped hypergranulosis and acanthosis, and then pigmentary incontinence. These wedge-shaped hypergranulosis and acanthosis match with this Wycombe stria, and the pigmentary incontinence match with the post-inflammatory hyperpigmentation. Moving to another disorder, which is pityriasis lichenoides chronica, which is a disorder that clinically may pose some diagnostic challenge. It's not easy to recognize sometimes, but dermoscopy may be of great support. Here you see an example of PLC. And here you see the typical dermoscopy presentation, which is polymorphic vessels, milky red areas and globules, linear, irregular, and branching vessels. whitish scales, and orange and yellowish structureless areas. Again, here there is another case, yellowish structureless areas, whitish scale, and polymorphic vessel. This is histopathology. As you can see here, hyperparokeratosis, acanthosis, red cell extravasation, and hemosiderin, perivascular interstitial inflammatory cell infiltrate, basal cell degeneration. But the one who match with our dermoscopy finding is hyperparokeratosis and red cell extravasation of hemosiderin. Hyperparokeratosis here correspond to these whitish scales. Red cell extravasation in hemosiderin here correspond to these orange yellowish structureless areas. And these dilated blood vessels correspond to these polymorphic vessels here. Moving on, Grover disease, another disorder which is not easy to diagnose. At clinical level, it may resemble other disorders, but remember that Grover disease may be distinguished into diarrhea-like or eczema-like. What we will discuss is the diarrhea-like variants, dermoscopy, polygonal, star-like or oval-shaped yellowish brownish area surrounded by a thin whitish halo here. Don't forget this polygonal, star-like or oval-shaped. This is the histopathology of the diarrhea-like Grover disease. And this is the histopathological findings that match with dermoscopy findings. In this case, hyperkeratosis and parakeratosis, these focal areas of hyperkeratosis and parakeratosis correspond to these polygonal, star-like or oval-shaped yellowish brownish areas. Don't forget the diarrhea disease as dermoscopy features similar to Grover disease, diarrhea-like type, as I discussed 1 second ago. So don't forget that the two disorders, diarrhea disease and Grover disease, diarrhea-like type, may look similar at dermoscopy level. In this case, is very important, the clinical presentation. Finally, Zune balanitis, another super common. We don't do biopsy anymore in patients with Zune balanitis. Oranges areas, carved vessels, the typical color here, and those are the typical dermoscopy findings, carved vessels, oranges areas, and this is the histopathology of Zune balanitis and vascular dilatation and extravased erythrocyte and hemosiderin are the two histopathological findings that match with the dermoscopy findings. Extravased erythrocyte and hemosiderin match with the oranges areas, and the vascular dilatation match with carved vessels. I think it's over. 15 minutes are gone, and I thank you for your attention.
Hello everybody, my name is Francesco Lacaruba from the Dermatology Clinic of the University of Catania in Italy. Thanks to the organizer for the invitation, and my topic is dermoscopy of parasitic and infectious disorders. As we will see in parasitosis, dermoscopy allows the direct visualization of the parasites, while in other infectious disorders, we can observe the clinical and histological skin changes induced by viruses, bacteria, or fungi. So let's start with parasitosis, and in particular with scabies. The approach to scabies has been revolutionized by dermoscopy. Skin scraping is no more performed in the majority of cases, as dermoscopy is more sensitive, fast, and also well accepted by patients. and the use of dermoscopy in scabies is nowadays approved by the international guidelines. The jet width control represents the dermoscopic sign at the standard magnification. At high magnification, the dark triangular structure corresponds to the pigmented mouth and anterior legs of the mite, while the contrail corresponds to the burrow that may contain the eggs. And at a trained eye, the diagnosis is easy in the majority of cases at low magnification. So we always start observing the suspicious lesions with the manual dermatoscope, and higher magnifications that, as you know, are obtained with the video dermatoscope may be used for a further confirmation. High magnification definitely allows a clear visualization of the oval body of the mite, the head, the legs, eggs, and feces. And high magnification is particularly useful in post-therapeutic follow-up. In fact, in some cases at low magnification, splinter hemorrhages due to scratching may mimic the dark brown triangular structure of the mite, while high magnification clearly identifies the hemorrhagic spots, and this is an empty burrow with no residual mite. And the high cost of the video dermatoscope does not represent a problem, as we demonstrated that low-cost video microscopes of about $50 that allow high magnification enable the optimal identification of the typical signs of scabies, similarly to standard video dermatoscope. The so-called pseudoscabies is probably underdiagnosed. It is due to Sarcoptes species for which animals are the normal hosts. On human skin, these mites are not able to produce burrows, so the clinical diagnosis is very difficult. But dermoscopy, and in particular high magnification, allows the identification of Sarcoptes scabiei which have a similar morphology in the different species. Moving to pediculosis, dermoscopy ensures a more detailed in vivo evaluation of the parasites and nits. And dermoscopy also allows an easy differentiation between full viable nits and empty non-viable nits, and this is an important information for a correct therapeutic approach and in treatment monitoring. And dermoscopy also allows a fast differentiation from other entities that mimic nits called pseudonits. For example, seborrheic scale or debris or hairspray or gel which appear as these whitish amorphous structures. Or, for example, hair casts that are generally secondary to psoriasis or lichen or traction and that appear as elongated tubular structures encircling the hair shaft. For example, this is a case of hair shaft due to pigtails. Another cause of pseudonits is the white pidra. It is a fungal infection characterized by these multiple ovular whitish masses along the hair shafts. And the trichobacteriosis is another entity that may simulate nits and shows these yellowish adherent aggregates around the hair shaft. In this case, the cause is the Corynebacterium, generally in patients with poor hygiene. Of course, the presence of trichobacteriosis does not exclude the contemporary presence of Phthisis pubis, such as in this patient or in this other patient. But dermoscopy may be also useful in other pruritic infestation. For example, in this 80-year-old woman with a history of diffuse pruritus and the presence of erythematous macules and escalations. In this case, we clinically noticed this brownish parasite moving on her back. And with dermoscopy, we were able to identify, of course, with the aid of this entomology book, the presence of Dermanissus gallina. This is an hematophagus ectoparasite that affects birds and sometimes humans, causing itching. This is another case, a 75-year-old man with a 2-week history of diffuse pruritus and some papular lesions. In this case, with dermoscopy, we identified different oranges parasites corresponding to the Neotrumbicula autumnalis. Adults parasites of Neotrumbicula live on the soil, but larvae need to parasite warm-blooded hosts, including humans, and causing pruritus. Demodicosis is an inflammatory disease characterized by erythema and papules of the face associated with burning or pruritus. But it is due to the hyperproliferation of another parasite, Demodex folliculorum, that is part of the resident cutaneous flora. Demodex locates upside down within the follicular infundibulum, causing an inflammatory reaction. And in demodicosis, dermoscopy is able to show these yellowish threads protruding from the follicular openings, as you can see also in this other patient. And confocal microscopy clearly shows that these yellowish threads correspond to the Demodex tails and also to the follicular hyperkeratosis. And is also promising the use of dermoscopy for treatment monitoring of demodicosis as suggested in this study. Moving to viral infections, dermoscopy is diagnostic in HPV infection and molluscum contagiosum. As we will see in both cases, the dermoscopic features reflect histopathology. Viral warts are characterized by the elongation of the dermal papillae that contain enlarged capillary vessels. And in papular warts, these aspects correspond to the so-called mosaic pattern. This pattern consists of a whitish network containing red dots, and in digitate warts we observe another pattern, the so-called finger-like pattern, characterized by multiple papillomatous projection containing elongated vessels. This is another example of the mosaic pattern, and this is an example of the finger-like pattern. And as you can see, the projection arises from a common base and are generally outlined by a whitish halo, as you can see also in this case. Dermoscopy allows an easy differentiation with the physiological peripenile papules. These frequent lesions show multiple regular small projections, and in some cases these projections present fine vascular structures, as you can see here. The similar pattern may also be observed in physiologic vestibular papillae that are often misdiagnosed with genital warts. Fordyce spots are also misdiagnosed as viral warts, but dermoscopically they are completely different. They show these yellowish lobules surrounded by a vascular network. Also, cutaneous warts show the mosaic pattern and the finger-like pattern. This is, for example, another case of mosaic pattern in a cutaneous wart of the face, and an example of the finger-like pattern in a case of cutaneous wart of the scalp. Do not forget that non-pigmented seborrheic keratosis may show a similar finger-like pattern, like also in this case, so dermoscopy, as usual, must be interpreted in the clinical context. In plain warts, we can observe these small red dots on a whitish background, while in palmoplantar warts, we observe a characteristic yellowish color with loss of the dermatoglyphics and presence of typical brownish hemorrhagic spots, as you can see also in this other case. And in this case, dermoscopy allows the differential diagnosis with traumatic hyperkeratosis, which does not show interruption of the dermatoglyphics or hemorrhagic spots. And also in this case, dermoscopy may be used in treatment monitoring, as it is able to clearly show the complete resolution, such as in this case, or in other cases, the persistence of residual lesions. Moving to Molluscum contagiosum, the histopathology consists of a well-defined endophytic hyperplasia, and the central invagination corresponds to the clinical umbilication. The invagination also corresponds to the typical roundish yellowish area seen at dermoscopy, that is also called pore. And it in molluscum, it is associated with the linear and branching vessels. The yellowish pore may be single, such as in this case, or multiple. In other cases, the pores are clustered and form a polylobular yellowish area. In any case, the dermoscopy aspect of molluscum is characteristic and allows an easy differentiation from other entities in almost all cases. And dermoscopy is particularly useful in case of minimal cases of molluscum contagiosum, in cases of unusual presentation or unusual localization. With dermoscopy, we can easily distinguish a molluscum from warts. For example, in this case, they were present in the same patient. This is the last section of my talk, fungal infection, and in particular in tinea and capitis. In addition to desquamation, we have a range of dermoscopic features due to the fungal invasion of the air shaft, which this fungal invasion may cause bending and breaking. These features consist of the classical comma hair, bent hair, broken hair, and Morse code hair. These are also called interrupted hair and present alternating white and black bands. At high magnification, we can see that in the Morse code hair, the white bands represent areas where the air shaft is less resistant and is more prone to bending and breaking. This is the zigzag hair due to multiple bending. And the so-called corkscrew hair are a further aspect generally observed in patients with curly hair or in case of trichophyton infection. So these are the main dermoscopic features of tinea capitis that may be also observed in other dermatophytosis, for example in tinea incognito, or in dermatophytosis of the eyelashes that is called tinea ciliaris. Again, we can observe scaling, Morse code hair, bent hair, and broken hair. In this region, dermoscopy allows an easy differentiation, for example, with scaling of psoriasis of eczema, as in this case the hair shafts are normal. While in pityriasis palpebrarum, we clearly observe the nits or the parasites, the Phythius pubis. And finally, in candidiasis, dermoscopy shows the presence of these white amorphous roundish masses, also called cottage cheese-like structures, that correspond to the typical yeast colonies. In this case, of course, the main differential diagnosis is lichen planus that shows the typical Wickham stria. Both common disease may be associated, of course, such as in this patient. In conclusion, dermoscopy is nowadays crucial in the clinical practice for the diagnosis of skin infection and infestation. And as we have seen, it is often very useful also in treatment monitoring. Thank you very much for your attention.
I am Emilia Cohen-Saban from Buenos Aires, Argentina. The nasal capillaroscopy is a non-invasive, simple, low cost and safe technique for the detection of microvascular abnormalities. There are many devices, but I usually use a dermatoscope to perform capillaroscopy, which I have attached to a camera for taking photos. The use of nasal capillaroscopy in the diagnosis of systemic sclerosis is well established. Since 2013, it has been included in the new classification criteria for systemic sclerosis, and it is considered a key in very early phases of the disease as a result of a multi-center project running by the American College of Dermatology and the European League Against Rheumatism. A score of 9 or more is required for the diagnosis with a 98% sensitivity. Raynaud's phenomenon is the most common initial manifestation of scleroderma, which may precede other symptoms by many years. Around 50% of primary Raynaud's phenomenon will develop to secondary Raynaud's phenomenon. And so at present, it still is a challenge. So the main goal of capillaroscopy is to differentiate between primary Raynaud's phenomenon, in which capillaroscopy should be normal, and secondary Raynaud's phenomenon, in which we can see many capillaroscopic changes, as in this case that you can see giant capillaries and dilated capillaries and a lot of microhemorrhages in a patient with CREST syndrome. Moreover, capillaroscopy is a useful tool to predict in a Raynaud's cohort without any other signs of connective tissue disease who of them will develop secondary Raynaud's phenomenon, particularly due to systemic sclerosis. In a prospective study, Kemich and co-workers observed that patients that almost 80% of patients with the combination of only Raynaud's phenomenon without any other clinical signs of disease, plus nasal capillaroscopy typical for systemic sclerosis, plus specific autoantibodies for systemic sclerosis, will develop definite systemic sclerosis during a 20-year follow-up. In addition, they found an increased frequency of scleroderma pattern from 58% at baseline to 88% in patients who experience progression to definite systemic sclerosis. This is a very good example of what I said. This is a patient of mine. Her first visit was in 2019 when she was 29 years old, and she presents with only primary Raynaud's phenomenon at the clinical level, but her capillaroscopy shows typical changes of systemic sclerosis, the so-called scleroderma pattern, and her lab confirmed specific autoantibodies for systemic sclerosis and antinuclear antibodies with a centromere pattern. So this is what we know as preclinical scleroderma. And this is when capillaroscopy provides a possibility of pre-diagnosing or a very early diagnosis of systemic sclerosis. The scleroderma pattern is composed by dilated and giant capillaries, hemorrhages, avascular zones, neoangiogenesis with abnormal capillary shapes like ramified or bushy capillaries, and distortion of the architecture, and it was described by Maric et al. And here we can see the scleroderma pattern. The most specific abnormality is giant capillaries, which by definition is an homogeneous capillary widening of more than 50 microns. Further, the scleroderma pattern has been divided in three phases or in three stages: the early, the active, and the late pattern. This is a normal capillaroscopy, and we compare the normal with the early scleroderma pattern, and you can see here a few dilated and maybe one or two giant capillaries and a few microhemorrhages, but a well-preserved capillary distribution. We can compare the early, the normal, and the active SD pattern, and in the active pattern, you can see an increased number of dilated and giant capillaries, an increased number of microhemorrhages, the beginning of capillary loss, and a mild disorganization of the architecture. And finally, in the late stage, maybe you have a chaotic scenario with extensive avascular zones and neoangiogenesis with abnormal shape of capillaries like ramified or bushy capillaries, and a real disorganization of the capillary distribution. As what is important to note is that these stages of scleroderma pattern have a very good correlation with disease activity, and in particular the late stage correlates very well with internal organ involvement, particularly with interstitial lung disease and kidney disease. Although the scleroderma pattern is highly specific for systemic sclerosis, similar findings can be seen within and without the scope of scleroderma pattern spectrum, like dermatomyositis, polymyositis, overlap syndrome, mixed connective tissue diseases, systemic lupus, and other conditions with sclerodermiform changes such as the diabetic hand. So, take-home messages: dermoscopy is a useful tool to perform capillaroscopy in the daily practice. Giant capillaries and avascular zones are definite markers of microvascular involvement, and capillaroscopy is a very important tool not only for diagnosing and monitoring the disease, but also to identify patients at risk of visceral involvement. Thank you very much.
Buenos dias. This should be the first words for this presentation. But at present time we are not in this very beautiful Argentina, and you see this dermoscopic picture from Horacio Cabo. But we take part at the virtual World Congress of Dermoscopy now. So I'm very happy and thankful to present you the dermoscopic pearls in the diagnosis of mucosal lesions. Thank you very much to the board members of the IDS. Hello from South Germany. A little bit foggy, and I hope to clear up the fog now for you. Please consider and do the examination of the mucosal membranes also during the pandemic. This is our issue when we do the total body skin examination. So ask the patients after removing the face mask and do not talk. Please remove the face mask, stop talking, and open your mouth. We can apply our dermoscope at the mucosal membranes when possible, and this was a suggestion long time ago from Professor Alfred Kopp from USA. Just apply a food wrap around your dermoscope and use it for one, or it's usable for one use. So nowadays we do have special items of different companies which we can apply on it and use it for this. I'd like to share with you this case. We have seen this lady several years ago with this new spot at her female genital area, and her gynecologist has applied for 4 weeks steroid cream locally. She did it, and then after no changement he transferred this lady to our unit. So we were able to take a picture dermoscopically. And now the question to you, what would you do? Is it benign, malignant? Would you do local treatment, or would you recommend an excision and biopsy? So let us enter into mucoscopy, and at the end I will present you the result of this case. So we have started more than 10 years ago under the umbrella of the International Dermoscopy Society, and we found some very helpful algorithm in the part of mucoscopy. So when you see any blue, gray or white colors in a lesion, be aware and exclude any malignant tumor. And optional, you can add some structureless areas in this algorithm. So this was the results of our study. And this word mucoscopy has been inaugurated, so far I know, in 2017 by Dr. Jha from India, and several times it appeared again in PubMed, and I like this work mucoscopy, therefore I will keep going to use it. The last study, so far I know, under the umbrella of the International Dermoscopy Society has been also done by Dr. Jha from India and a lot of colleagues, which highlight the squamous cell carcinoma at the lip and its histological differentiation. I show you at the end a nice summary to do this in your daily practical work. Some examples. This is a benign melanocytic macula, and I show you some images from our study more than 10 years ago. Nevertheless, it's still valuable because we do see a lot of patients day by day with lesions at the mucosa, so on the lower lip, this brownish macula, light brown and kind of lines, not really structureless, so a benign lesion. In contrast, you see this lesion here with brown, blue, gray and white colors, structureless kind of streaks or lines, yes. And in the upper part, you see here at around 12 o'clock, you see lines of vessels, a little bit atypical. So all of us would say we do need the surgery. The best part is to do the complete excision, and it was a severe dysplasia of a melanocytic lesion, not a melanoma in situ or an invasive melanoma. In contrast, and you see here a case of Olga Simonescu, she was also a very important collaborator and author of our paper in 2011. A lesion which looks like a little bit reddish, blue, whitish, so structureless areas, then you would say, oh, it looks like a malignant lesion. From the classification, it's absolutely correct, but there's an exception for the angiomas. They can present like this, and you see it also clinically. It is more obviously an angioma. In contrast, also a case from Olga, you see an invasive melanoma in advanced stage, also from Romania, and you see structureless areas which are blue, gray, white. You see a high variation of the colors, and clinically it is obvious that you have a melanoma. However, take your dermoscope, check it dermoscopically, and learn from the structures. Also here, a lesion which is present since birth, and you see homogeneous brownish area, structureless, no hint for any malignancies. So you have a congenital nevus and ask for the self-examination by the patient. Here, in contrast, you see an advanced melanoma in a patient older than 100 years old, from a colleague of Cologne in Germany, and clinically it is obvious you have the melanoma. However, check it with the dermoscope and you see brownish, grayish, blackish colors, atypical structures. So you have structureless areas, but a typical kind of network, kind of lines. So completely different, completely chaotic, also a little bit reddish parts, and then you know you have the melanoma here. Also, you can use a mucoscopy for inflammatory skin lesions, skin areas, skin diseases. Here an example of the lichen rubor, and we know some different differential diagnosis, and we will learn more and more from now and in the future. Here you have the lichen rubor with the white lines, whitish areas, also some little bit dotted vessels for the representative inflammation here for the lichen rubor. Also, in the area of the mucosa or closed area of the mucosa, still in a normal skin, you see here this large area on the two buttocks, and have a focus on the left hand side of the lesion with this in lines arranged dotted vessels, sometimes glomerular vessels. And when you hear this, you know very good the rule from Harald Kittler from Vienna in Austria, that when you see the features of the dotted vessels in the line, you have a boinoid-like lesion, and here it was a Bowen's disease. So suns come up, and we learn more and more about mucoscopy. So we go now into the clinic. So all pictures were taken before the pandemic. Now just let us think about the pandemic situation. So I ask my patients when they have the face mask still on their face, so please stop talking now and please follow my rules for the next second. So stop talking, remove your face mask, open your mouth, do not talk. Thank you. So you check it inside and you say, please elevate your tongue. Thank you. And then you see this reddish tumor there, structureless reddish. So we were able to take a dermoscopic picture. This was before the pandemic. and then we see this reddish lesion, a little bit whitish. Yes, I must admit this, but the reddish part is the main important thing. Well, this was new for the patient, so I said, please come back after 4 to 6 weeks. The patient came back after 6 weeks. It was completely disappeared. The lesion was new for the patient. There was no hint for any malignancy at the first consultation, so it was a diagnosis of the traumatic blister after any possible injury. We move to the next patient. So after removing face mask, do not talk, please. Open your mouth, please. And then everything is fine inside. Please elevate your tongue. And then you see this bluish, structureless, grayish lesion, a little bit on the left-hand side of the tongue of the patient, near to the teeth inlays. So try to do dermoscopy. It was very hard, and you see that on a dermoscopic picture is not quite helpful. Better is a clinical picture in which you see all the relevant structures of the lesion based on the now liquid area in this area, so you can just look inside of the lesion. We did a very thin excision, and we found the result of the amalgam tattoo, which was correlated to the inlays of the teeth. So consider, please, all the local circumstances and combine this, and to do your clinical dermoscopic diagnosis and for the next step for your procedures. When we move to the lips, so just the frontier between normal skin and the initial starting mucosa, take your dermoscope, do mucoscopy here as well, and you check it with, or you see here at the UV damaged lower lip here with this squamous areas, a little bit distinct on the right hand side, a little bit you see some vessels with the lines here, but the main part are the squamous areas in the center. So you have the actinic cheilitis. And when you wait long enough, or the patient come late, then you have the tumor mass here with this hyperkeratosis in the lower lip of the male here, and in the surrounding you see these vessels in a line, hairpin vessels, a little bit chaotically on the left hand side, lower side, dotted vessels. So I like to call this polymorphia of vessels, which is a hint for any initial or starting malignancy, and we found here squamous cell carcinoma in initial stage. Also, we can learn from cases to cases. This was a case more than 10 years ago with this lesion, and I took the image from the image dermoscopically, and I didn't know what it was, so I asked the patient to do a very thin shave biopsy. He refused. He wanted to go into holidays, so he went into his holidays. I was sitting with the images there at the evening. I sent it to some colleagues, and I got some answers which I like to share with you. The first was vascular, possible something happened in this area, and well, not quite sure what it is. The second one said, well, it looks like an angiosarcoma. The third one was hemangioendothelioma, Kaposi, traumatic. I would exclude melanoma. Next one sent the answer with angiokeratoma. Please rule out angiosarcoma. Next was very pragmatic, BCC. Have you ever seen a BCC at the mucosa? Kaposi. And the last one said, well, it could be an angioma, benign or borderline, angiosarcoma, plus could be also an extensive hemorrhage on the base of lichen sclerosus et atropicans. Patient came back. I did a very thin shave biopsy, and it was proven that it was an hemorrhage on the base of lichen sclerosus atrophicaans. So we learn every day, and it's good to learn for yourself, especially for the patients, and we are able to share this knowledge either in conferences or even virtual, which we are doing today. So coming back to our case in the beginning, so you know this lesion, older female patient, very new, no change of a local treatment. This was a dermoscopic image with wide area, structureless areas, and a kind of polymorphia of vessels, very distinct in the lower part between 5-6 o'clock. And we did the complete excision, and this was the very first amelanotic mucosal melanoma, 1.3 millimeters. This was my first amelanotic mucosal melanoma. We have checked the literature, and we found it was the first published, so we publish the first published amelanotic mucosal melanoma. So be aware, in the nature all is possible, and even after a long experience, nearly now 30 years in dermoscopy, I learn day for day something new, and I'm happy to learn it for myself, especially for the patient, and to share this knowledge with you. So conclusion, blue, gray or white colors, be aware something goes wrong. Optional, you can add structureless areas, and especially when you see polymorphia of vessels, please exclude any malignancy. In conclusion, the melanoma can have different part of different types of dermoscopic features, and different colors, and also it can has only wide structureless areas, possible polymorphia of vessels. In bone disease, you see this possible arrangement of dotted vessels in a line. And in cheilitis actinica, you have this squamous part in the center, possible initial typical or dotted vessels, perhaps vessels in the line. And when it's more advanced and you get the invasive squamous cell carcinoma, you have more tumor mass with some squamous areas and more polymorphia of vessels. So thank you very much for your attention. Hopefully it was, or I hope it was very helpful for you. Stay passionate in dermoscopy, in mucoscopy. Have a good virtual World Congress of Dermoscopy, and please stay healthy. Goodbye from Germany.
We are starting in 5 seconds. 5, 4, 3, 2, live.
Vessels, perhaps vessels in the line, and when it's more
You can start.
Hello. Hello, my name is Rainer Hoffmann-Wellenhof, and I want now to start the discussion. I want first to thank all the presentators for their excellent presentations, and maybe also anyone of this discussion round may introduce her or himself, that we know how we are speaking, with whom we are speaking. So please start just and that we can check if everybody is online.
Online.
So you can switch your microphone on.
Yes.
And then discuss all the presentations, and may first you can introduce yourself a little bit. Okay. Just start to introduce yourself, because I don't know if everybody in the virtual world is knowing our names and what we are doing and where we are from. So I am Rainer Hoffmann-Wellenhof from Austria. I am the old treasurer of the IDS. Then, who is next?
I am Dr. Abhijit Jha from India.
Great to see you from the other side of the world, more or less.
Yes.
I am Emilia Cohen-Saban from Buenos Aires, Argentina.
Great, thank you.
I'm Andreas Blum from Germany. Well, I gave a lecture just recently.
Yeah,
Hello.
we heard it, of course, Andrea, thank you.
And my name is Paweł Pitkiewicz. I'm a dermatologist, neurologist from Poznań, Midwestern Poland. Yeah, that's it.
Great. No, it's perfect, I think so.
Hello, this is Giuseppe Micali from Italy, and Francesco Lacaruba. We are both from Italy, same department.
Yeah, and great presentations too. Thank you so much. Yeah. So now I think it's open for discussion. I didn't see any questions in the chat because probably I was not able to see the chat. Do anybody saw any questions to your lectures?
I have a question.
Okay, so please.
To Dr. Micali. Have you ever seen dotted vessels in Sun's balanitis? Why do you laugh?
You know that dot vessels can be seen in other disorders, right? But the point is that when you see a monomorphic expression of dot vessel, then that is more indicative of psoriasis. But dot vessels, isolated or little cluster of dot vessels, you can find in many other diseases, including Sun balanitis. And of course, for instance, another one that comes to my mind is Bowen disease, of course, for instance.
Yeah,
right?
of course. Perfect. And I have another question to Andreas. Have you ever seen black color in genital melanotic macule, particularly in women?
No, I haven't seen it, but it is very rare. So
okay,
it's not a good answer because I do not have a good overview over hundreds and hundreds of cases. Yeah, I have only few cases, and in congenital nevi, I've only found brownish colors so far.
Okay, thank you both.
So I also want to ask a question, especially for the specialist in inflammoscopy. So do you really omit sometimes a biopsy because you are so sure with your clinical and dermoscopic diagnosis, or you just look for the best location where you do the biopsy? Because of course we saw all your beautiful pathologic correlation to the different dermoscopic features. So I wonder if you still do biopsies or not.
You know, I presented that correlation for educational purposes. But normally for psoriasis, we don't do it anymore. We don't do it for Sun balanitis. I mean, unless there is something that does not convince us. But normally, regarding that disorder I covered, I would say the minimum % of the patient we do biopsy.
Okay.
I just wanted to show the correlation, so to strengthen the importance of dermoscopy. Because once you know that what correlates that histopathology, you feel more confident in relying on dermoscopy.
For lupus erythematosus, you still do a biopsy or not?
Rarely, very rarely. Very
really
rarely.
Great.
Yeah, I think that we are very happy that we are here today because it's where the future of dermatoscopy is, not the whole one when they talk about skin cancer, because in our offices we see exceedingly more inflammatory lesions. And if you know what we are looking for, it's of a great help. So we can use inflammoscopy for follow-up treatment, for observing the evolution of the lesions. And as Dr. Michele said, it saves time, it saves patients money or healthcare money. It saves the patients from biopsy. and we get more time till the correct diagnosis. So it saves patients time and save us from pitfalls when we are left with a dilemma. Maybe it's this one or something else, and we put the dermatoscope and say it's lichen planus, or it's not a lichen planus, but granulomanulari or porokeratosis. I personally had a case of genital porokeratosis that had been treated as lichen planus for 15 years, and then a surprise, it's something else. So when we get the diagnosis, we can start a tailored treatment, not just steroid treatment or tacrolimus.
I just want to make a final comment. Whenever the clinical presentation is unusual and does not convince, then I will do a biopsy, definitely. But then when it's a clear cut, as the example that I showed, we don't do. But if something looks strange, then I'll do a biopsy, because you know what? Still, it's like 10 to 15% of patients in which we do a biopsy. So what? If you do a biopsy one every 10 patients or 8 patients or 7 patients, we used to do 100% biopsy. So still, whenever I have something I teach to my residents also, wherever something sounds strange, it's like with pigmented lesion, right? You know, if you don't, as you said, that white macules, if it does not convince you, do a biopsy or don't hesitate. So that's the message.
May I also add something about inflammatory diseases and dermoscopy? We in Central Europe have to learn also to use the dermoscope in more colored skin, because we do see more and more patients with colored skin type 3 or 4 or even darker. But we are not used to use here the dermoscope because we do not know really good the features. And there was a nice thesis by a colleague from Tanzania, and they have the problem that the people are coming from the countryside and after a walk, even over days, and then they come to the medical center with a skin disease. And she was interested in if the dermoscopy can help also in colored skin. And she found out that in some diseases it's quite helpful, and they now avoid taking biopsies because they can name the diagnosis only based on dermoscopy. So we have also to think more and more abroad and to apply dermoscopy and inflammoscopy also in not only in lighter skin but also in darker skin. I found this very fascinating.
Yes, we have also an expert from India.
Yeah, we actually
how's the situation in India?
It's getting better now. It's getting better now.
Okay.
There are fallen cases, COVID cases now.
And you use also, I think, the dermoscopy more for inflammatory diseases because it's not so important to tumors, right?
We see a lot of inflammatory cases daily, and in our hospital we have a very busy schedule with lots and lots of patients, and mostly inflammatory. And I found in erythroderma also, even dermoscope helps. In 2 of our cases, one was diagnosed as PRP, pityriasis rubra pilaris, where we had seen a yellowish oval background along with central hair. So we could easily diagnose that as pityriasis rubra pilaris. So I would also recommend or tell we should even try dermoscopy in erythroderma cases. At times, we are able to clinch the diagnosis.
Yeah, great.
In capillaroscopy, we have the problem that if the periungual fold is pigmented, we cannot see anything. It's terrible.
So I have a question for Professor Bloom, practical question. How did you obtain these beautiful photos of the mouth? Did you use a special dermatoscope or standard dermatoscope with the camera?
I think the patient swallowed the dermatoscope.
Very
We have
small.
still the problem, the camera is still in the gut. No. No, it was by chance, and the lady, she cooperated very good, and also the male patient, but it is very tricky. And what I found afterward is because the mouth inside the mucosa is liquid, you do not use a dermoscope because you see it based on the clinical image, and you can run at the mucosa, especially in the mouth, mucoscopy without the dermoscope. Only the clinical image is helpful.
I think I'll just add a few things on that. While doing a mucoscopy, you can actually enlarge your field of vision by using a cheek retractor one. You can use a Calagion clamp too. These two actually help us to increase the field of vision. When we use a cheek retractor, plastic cheek retractor, that will help us to even go deeper and add on. But with Dermlight 4, generally we cannot go inside. You can use a Dermlight 2 hybrid or a thinner mucoscope. So I think that would be a better way to even get that image too. So I've tried a lot of cases, and we are still trying to publish a few more cases on actinic cheilitis and so on. So I think it'll be coming in the future. About to compile that.
Very good. May I just ask you the last question from Emilia about the congenital nevi or black colors in congenital nevi in darker skin. Have you seen this in your patients?
I didn't ask about congenital nevi. I asked about a melanotic macule.
Yeah, so melanotic macule also in darker skin, for example, in India. Have you seen this?
Have you seen black color? Because this is a very confused or challenge scenario about melanoma and melanotic macule. If you see black color, I think that it's more challenge the diagnosis, because this problem or this issue, I ask about black color.
And have you seen in India, Abhijit, have you seen this black color in melanocytic macule?
No, not yet. And we don't generally see that. But what I've observed in a few cases of SCC, we get a lot of pigment dots. And we also have got physiological lines on the lips. We also get physiological lines on the lips. So we generally confuse that with something else, some kind of melanocytic nevus. So we have to understand that physiological pigmentation of the lip is quite common in India, or skin type 5 and 4.
Yeah, that's interesting. This is interesting.
Okay.
Yeah.
Other comments, questions? Now we have the experts here.
No more questions. Please send us the questions.
Andreas, do you really look the genital area by each patient? Or do you just ask?
No, in males, I ask to remove the preputium. I ask the male to elevate the genital by himself, and afterwards I spray a little bit disinfection spray on his hands. And for females, I say, sorry, they are standing with the bra and under trousers in front of me. And then I say, sorry, I check it from the outside. And then I ask for the females if they have noticed by themselves or by the gynecologist any change. And so we have a very good collaboration here with the gynecologists. They are sending all the pigmented lesions or the lesions at the genital area to us. And so I ask the ladies, and I also ask the ladies, when was the last control by a gynecologist, but I look from the outside. But I look from the outside in each patient, and also for the buttocks.
Okay. Other comments, questions?
Maybe in regards to Dr. Lacaruba's lecture and parasitic infections, I was not aware that we have so many other parasites than with the names I can't even repeat. So that impressed me. And in regard to scabies, there was a sign of a jet with a contrail. And we've discussed it a few weeks ago in the Dermoscopy forum that it's rather a delta wing bomber. So maybe B-2 Spirit stealth bomber, American one. It's more of triangular in shape.
Yeah, there are a lot of names for not only for scabies but also for other infectious disorders. As you know, we tried to do a standardization of inflammatory infectious disorder terminology in infectious and inflammatory disorders that has been published in the British Journal of Dermatology last year. With the IDS, of course, and for many features we obtained a consensus, but for many features it is very difficult because they are descriptive, especially in infectious disorders. And I think that there will be other description in the future that will be very may be confusing because in this area it's difficult to obtain a consensus, as you know. But
of course, we all love the metaphoric language, you know?
Yes.
We all love it because we can better remember it, I think so. Therefore, I also love it very much. Yeah, and I like the bomber, of course, too.
But how can you call in another way the nits or psoriasis, so the mite? So there is no other way we can call it. We just see it and we know what it is. There is no analytical approach in that. So there are no segmented lines, radial, and so on. It's so artificial.
Yes, for vascular features or scales or color is easy, but for these features is difficult and in some cases impossible, maybe. Okay, for the question about skin of color in infectious disorders, there are not so many differences with wet skin, of course. Only scabies, it is a little bit difficult to look for the barrows. But if you have trained eye, you can see the barrows also in their skin, of course. For the other features, for the other disorders, molluscum, warts, and so on, the features are the same in both cases.
I think in skin of color, the background is really important, and the vascularity in other diseases like inflammatory disorders, we generally don't get so much of clarity as seen in white skin. So I think the vascularity and the background is really better in seen in white skin rather than in skin of color. That's what I think.
Yeah. What we have found in people from Africa, from Tanzania, that we have the problems with as you told just before, we have problems with the vessels, which one we cannot see, very hard to see.
Yeah.
And then we miss the inflammatory impact, which we have in inflammoscopy, especially in acute skin diseases.
I agree, because normally the clinician is the one who is able to identify that minor changes in erythema, let's say after you start the treatment, after 1 week, and then you have these minimal changes in erythema, or even with dermoscopy you can see it, but with dark skin, all of these very helpful hints you will not able to see. That's one of the big issues on dermoscopy, of inflammoscopy in dark skin. Yeah, I agree, fully agree. That's a big limitation. And another thing is the rosacea. Rosacea in skin of color you do not appreciate the typical redness, typical inflammatory color of the rosacea. And there is also, clinically speaking, is very, very difficult to identify in Black patients.
I think the same is also true for the already treated inflammatory diseases, you know? If the patient comes with 2 weeks of local steroids, I think the diagnosis is also very, very difficult clinically, and of course also with the dermatoscope. So, and this is quite frequently the situation at the clinic, because it's treated by a general practitioner, and then it's very difficult, I think so.
Guys, I have a look to the platform and we have 2 questions.
Please
I will
read
tell
it.
you.
Yeah, this would be great.
¿Cuáles son? Esta. Okay. Elizabeth Sawyers asked, regenital exams. In Canada, we do pap test only every 3 years. It's a long time to pass and can miss things. Recent woman with stage 3 vulvar melanoma, last pap in 2018, case for examining genitals.
No. Andreas, I think this is for you, the question. Of course, I think
every year.
I know the lady who has asked this, but I didn't get the question quite good.
Me too. I didn't understand. What is the question?
I think in Canada, the gynecologist is only every 3 years. So it's much time in between. So I think the dermatologists have to do it.
Well,
what is your opinion?
No, I think, sorry, but I am a woman. I think that we have 2 ways and 2 opportunities to discover something. So go to the dermatologist and go to the gynecologist, please.
There's a most important way to detect anything is not a medical doctor. It's a person. It's a person itself. So it's quite good to do a self-examination regularly. And in some areas you need help by either your husband or your wife or your partner. And then this is the best thing to detect something in early stage. And then when you detect something which looks not nice or it is new, and when we are getting older and older, the risk is increasing that something goes wrong. And then when we detect something, then we need to go, we need to move. It's a self-responsibility. And not to say always the doctor should, but first the patient, the person should do something.
We may encourage the patients to self-examine by displaying posters in our offices, because in other way they may not even think about it. I had many patients with larger melanomas that they were not aware of, and the same applies to genital area or under the breast. I had a young woman with a melanoma, a scalp, but it's impossible for the patient to check the scalp by himself. He needs assistance. So a hairdresser, we should train hairdressers.
But what I always do in the clinical examination, I tell my patients, so today everything is fine. I do not know what's going on tomorrow, and therefore we give our patient, and we made this by our own, a description how to behave in the sun, and on the back side this is how it could look when it looks nasty, and when you notice any change in shape and or color, then please come. And we have a mole mole check, a quick mole check. So the patients are coming in. We check only this special mole, no more. And then we say in 80–90% it is benign, but in some cases we say, oh, you come very early, so we can switch you onto in our operation theater and we do the surgery as soon as possible. Yeah, so we need to say to the patients, today everything is fine, but be self-responsible. And then when you notice any change, and when you check yourself and with a partner or with a family, then come.
We have another question.
Okay. Please.
Any of you have experience in multiple vulvar melanomas in context of lichen sclerosis? I
Nope.
don't have.
No.
No.
Any of you? Okay. Please, another. Please, comment about tinea nigra of palms and soles.
Okay, this is a
Tinea
question
nigra,
for,
who wants to do this? Yeah.
okay, a question for infectious disorders, of course. I did not talk about this because personally I have no cases, but I know that there is a particular, of course, pattern characterized by pigmented spicules and dots. The particularity is that generally they do not found the dermatoglyphics. So this is the particular difference, special difference with, of course, melanoma, in situ melanoma, or hemorrhages. So these small spicules and dots that do not follow the dermatoglyphics. In cases of doubt, of course, the biopsy is, we can do, of course, the mycological examination. So the biopsy is very rarely performed. I don't know if some of you have direct experience with tinea nigra.
Yeah.
Because in Sicily, where we live, we didn't see any cases in our department.
Another question to Andreas.
I want just to comment for the tinea nigra. I saw two patients with tinea nigra, and I think the first thing it's the color, because it's not really so black as you would mention it if it's a melanoma. It's more in the grayish, and then you can stretch away a little bit. So just take a blade and stretch a little bit, and then it goes by. On the palms, it was, in my case, it was a parallel ridge pattern. So you can, of course, mix it up with a melanoma, but I think the color is very, very characteristic.
Okay.
So we have another question, yes, sir?
To Andreas, Andrea Ruiz asked, thank you all doctors. Dr. Bloom, for me it's still difficult to perform mucoscopy. Do you follow up, and how often do you recommend it for pigmented lesions on mucous areas?
Well, I do not do a follow-up when I cannot say it is 100% benign. Then I do not do a follow-up at the mucosa. Then I do either the biopsy, or best one is a complete excision. When I see congenital nevi or melanocytic macule, then I tell to my patients, please do the self-examination regularly by yourself. Yeah, but I do not do a follow-up at the mucosa because it is tricky, the mucosa, and then to miss, and which we have found with the melanotic melanoma there, it is tricky, and we still need to learn and to have more experience, especially for the malignant lesions in this area.
But Andreas, what are you doing with the lentigo, with the mucosal lentigo? You are very sure that it's a lentigo and you do not a follow-up image?
No.
So we do. So we do in Graz.
And have you found any change in the follow-up?
Yes.
And
of course,
change into malignancy?
It's growing, sometimes becoming more lesions. And so I also have one example where we have also a biopsy of a lentigo, and then years later, it turned out to be a melanoma. It was just one example, but we have it, yeah.
So it would be fantastic if you combine these cases into a publication or something like this, because we need to learn from this.
Yeah, so I think it's not a great effort to do a follow-up of an lentigo. Also, I think it's for the patient, it's very satisfying. You will not just look 1 second at the lesion and say, oh, this is just a lentigo, but oh, we will do a follow-up. So we do it, yeah.
Perfect. Andreas, you have another question. It said, Dr. Bloom, have you seen changes in color in the vulvar mucosa during pregnancy?
Yes, I have seen it, and we did also, because it was quite atypical, we did a punch biopsy during the pregnancy, and it was benign. And we did the follow-up after birth again, and it not really disappeared, but it got, the pigmentation was more distinct after the birth. What we see, this is sometimes once or twice a year, we see more pigmentation, but this is symmetric by females when they ride quite often a bike. Then we see it's a genital hyperpigmentation in both, so symmetrically we see it. And then I always ask the patients, are you riding a bike, or how often do you ride a bike? And we live in an area here in which we quite often ride a bike, and then with this one we see quite often.
Okay.
So you have to interpret this as post-lesional hyperpigmentation or post-inflammatory hyperpigmentation.
Yes. Post-inflammatory based to the pressure.
The biker's hyperpigmentation. You can publish this, Andreas.
Biker's macules.
Yes.
Biker's macules. This has been published. Sorry.
Okay. Do we have another question?
No
from
more.
the audience? No more questions?
No.
Anyone else who wants to say anything to this topic?
Thank you, everyone.
Yeah, thank you, of course, it's good. So I think we can close this session. So thank you again for all the discussion and the very, very good presentation, and have a nice congress. Bye-bye.
Thank you very much. Take care. Bye-bye.
Thank you. Have a good time.
Bye.
Gute Wanderung.
Bye.
Thank you.
Welcome and thanks for your participation in this virtual World Congress.
Visit the Photo Finder Virtual Congress booth and discover our skin imaging technology.
At the same time, in the lobby of the virtual Congress, you can play the artificial intelligence game Man Against the Machine and win some award.
And also don't miss out our imaging symposium on total body dermoscopy with great cases. It's on Saturday.
Enjoy the educational program, and whenever you have found some free time, enter the virtual booth and you will get to know us and our technology more in detail. Have fun.
Meet us online. Don't forget to play our Congress game, the Photo Finder Man Against Machine AI Challenge.
Just enter the virtual lobby of the Congress and you will be able to play the game.
Challenge the Photo Finder artificial intelligence and win interesting prizes.
Among others, the Photo Finder Downlight Handyscope and many other interesting awards. Play the game and have fun.
Good luck!
Because it is our duty to do our bit. Every time we care for a single person, we make the whole world better.
Welcome and thanks for your participation in this virtual World Congress.
Visit the Photo Finder Virtual Congress booth and discover our skin imaging technology.
At the same time, in the lobby of the virtual Congress, you can play the artificial intelligence game Man Against the Machine and win some award.
And also don't miss out our imaging symposium on total body dermoscopy with great cases. It's on Saturday.
Enjoy the educational program, and whenever you have some free time, enter the virtual booth and you will get to know us and our technology more in detail. Have fun.
Meet us online. Don't forget to play our Congress game, the Photo Finder Man Against Machine AI Challenge.
Just enter the virtual lobby of the Congress and you will be able to play the game.
Challenge the Photo Finder artificial intelligence and win interesting prizes.
Among others, the Photo Finder Downlight Handyscope and many other interesting awards. Play the game and have fun.
Good luck!
Because it is our duty to do our bit. Every time we care for a single person, we make the whole world better.